the Middle East, obviously United Kingdom, Europe, and America as well. So we are hoping to have a full house.
Do we have the contribution from Singapore as well?
Oh, absolutely. Yes, Ganga is online. Will be here very shortly. His protege is already online, and she has checked and she's going to speak to us.
That's wonderful.
Sampada, can I check whether
Ashok is online? Ashok, welcome. Harpreet, welcome.
Good morning, Sampath.
Welcome, Ashok.
Sir, good morning, sir.
Good afternoon. Hello, sir. Good
Good
afternoon.
afternoon. How are you? How are you, Sampath?
Good afternoon,
Doing
sir.
well, sir. Doing well.
Richard Collin is online. Ashok, he's kindly agreed to pop in for a few minutes.
That's lovely.
Hi, Richard. Ashok Grover is online. You know him.
How are you?
Indeed. I do indeed. He's looking very senior.
Very experienced.
Looks should be deceptive.
Here in India, Grover, sir. Good morning.
Morning. How are you?
Fine, fine, Grover.
Great to see you, Mr. Collin.
Well, very good to see you too. It's amazing that one is able to have what feels like a family gathering
Absolutely.
and see each other so well. It really is a big treat.
Great, really.
Okay. Sampath, do I check whether Dr. Surendran is coming on the line?
I can't see him yet. I will.
Okay, let me check. Let me call him on the phone.
Can you check whether TSS is online? Come on.
I believe he's on the line. Sampath.
Okay, let me just check.
Yeah. Where is he?
I can't. I'm sure you also can see.
So he's still not logged in, sir.
Still
No,
not
he
logged
said he's on the line. He said he's able to see us. That's what he told me over the phone.
So can he switch on his video and unmute himself? I think he mustn't have switched his video on. But even
So
then,
I
his
can't
name
even
should
see
come.
his name.
Yeah, his name is not there.
Let me
He's
check.
not there.
Hello, sir.
Definitely not there.
Video varliye, sir. Face varliye.
No, he's
check.
definitely not online at all. I can't see anything.
We're not able to see him.
Diana, can you check with Ganga whether he's coming online?
Okay, I will. Hold on. Thank you.
I spoke to him about 15 minutes ago. He said he's got the links and he will come online. We got about 100 already joined.
Very nice. Very nice.
That's amazing.
I think there's some problem with TSS. Let me check again.
Or if he wants to speak on your speakerphone, we can still hear him, Mohan, if he's having difficulty coming online.
I'll ask him to do that. Varla, sir. You're not coming. Amma, you're on the iPad, sir.
Mohan, can you mute yourself while you're speaking to him, please?
I'm sorry. You are on the.
Welcome, Javed.
Hi, sir.
Dr. Sampath, Dr. Ganga is currently logging.
Is
Dr.
currently
Ganga is
logging
currently
in. Yep.
logging in. Yeah.
Yep.
Thank
He
you.
is logging in. Yep. Thank you.
Richard, how is London doing with regard to COVID?
Well, we are, there's a big change coming tomorrow because Monday, for the
Yeah.
first time, we're opening some shops.
Okay.
Up to now, it's only been essential shops selling food, etc., that have been open. And from this coming Monday, we are able to use to have some form of a business as usual. We've got to have social distancing, which is they're arguing about whether it should be 2 meters or whether we can reduce that, and they'll go on arguing about it. And of course, the hospitals are. It's very difficult to justify doing some of the oculoplastic surgeries that we like to do, because a lot of the hospital beds are being kept for the potential of an increase in COVID-19. So
Coming off the peak now, you are descending, right?
we're absolutely, we're coming off the peak, we're descending, but the question is, as we descend, will we get a second peak?
Yeah.
And of course, that is how you descend is the subject of much conversation. But I think that's the same everywhere. I mean, we look at a country like New Zealand has done incredibly well.
Amazing.
And, you know, but then we all look as well at Singapore, and Singapore was doing extraordinarily well, but then perhaps not quite so well when they released the brakes a little. And I think, you know, we all look around the world. I'm very happy that I don't live in Brazil at the moment. But it's you know, it's and then one always questions as to how good the statistics are that one's being told.
Yeah. We are still ascending, but we have opened up already. The shops are open, markets are open, offices are open. But we're still ascending.
I think that's a sensible thing to do.
It is,
We are just 2 minutes away from starting, and the numbers are growing quite a lot. We are touching 125 now. So Ganga, welcome.
Ganga
from Northampton, welcome. Ganga, Singapore, welcome.
Hi, Sampath. Thank you very much. Thank you. Thanks for arranging.
Colin is online as well.
Yes, I saw his wonderful face. Is inspiring to have everybody on, especially Mr. Colin.
Ganga, good morning.
Good morning. Good afternoon, Mohan.
Singapore, good evening.
That's right. Nice to see you all.
Hello, sir. Please welcome.
Hi, Tristan. Hi, Senthil. Dr. Grover.
Morning.
Mr. Colin.
Good to see you, Ganga. Very good to see you. Hello.
Just great to see you. Just great to see you.
And you. I was very pleased to see that you weren't being left out. Wouldn't be the same if you were left out.
No. You being there is the most important thing. That's the first question I asked Raghavan.
You're very charming.
Ganga, you become younger during the COVID lockdown.
I wish. How are you all? Hi, Tristan.
Morning.
Right, team. We are a minute away from starting. Welcome, Bipasha, and the seniors whom I can see, and some. Obviously, there are so many now I can't see on a single screen. But all the speakers, all the chairs, very welcome, and a special welcome to Richard Colin. So, can we start, team?
Sampath.
Yeah.
Dr. Surendran is still having problem in getting in.
Can you get him on your speakerphone, please? At least he can speak to us.
Yeah.
Okay. Hi, this is Raghavan Sampath here from University Hospitals of Leicester, United Kingdom. It's a great pleasure to have you all on this inaugural international Zoom meeting on lid, lacrimal, and orbit pathology. My special thanks to all the contributors, panelists, speakers, and all the delegates as well, this being a Sunday, giving up time to be part of this. And I would like to invite Richard Collin. He doesn't need an introduction. He's a father of oculoplastics for United Kingdom, Europe. Almost all of us have been through his table at some point or the other. And I am what I am thanks to him to a large extent. And it's also a great pleasure to have Andy Curry, our surgical director from University Hospitals of Leicester, who's kindly agreed to say a few words because this is being hosted by us. Richard, can I request you to inaugurate this meeting, please?
Raghavan, thank you very much indeed. It's a real pleasure to do so. And it feels as though we're having a Sunday morning cocktail party and visiting all our friends throughout the world. And it's absolutely incredible that you have been able to put it together. It's a pity that it's put together because of COVID-19 and that is the actual cause. But like most things, we don't like the disease that we're fighting, but we can see some benefits because all the aeroplanes have stopped, our carbon footprint has improved, and we're actually doing what we thought was impossible to do, but we're being forced to do it by a terrible disease. And I think we're all incredible to see the benefits that come out of every set of circumstances and how we actually change. And it's wonderful to see a teaching course like this being organized and arranged with a zero carbon footprint. My only sorrow is that my colleague who wrote the color atlas of ophthalmic plastic surgery with me, Tony Tyers, is unfortunately no longer with us. And he died about a month ago, as most of you know. But I would like to just remember him as we go through a meeting like this, but for his wonderful contribution to teaching oculoplastic surgery, which is what we're all dedicated to do, and what you have done wonderfully in producing this meeting and continuing under difficult circumstances. Congratulations, and let's all enjoy it. Thank you very much indeed.
Thank you, Richard. Andy, would you like to say a few words? Andy is a Director of Surgical Services from University Hospitals of Leicester, and he's been very supportive of ophthalmology during this really trying time. Thank you, Andy.
Thank you, Raghavan. Firstly, I think I'd like to just echo what Richard was saying. We've all been through some very difficult times with the COVID pandemic around the world, which has affected everyone in many, many ways. But as Richard was saying, it is also impressive how, firstly, everyone has stepped up, and certainly within our own institution in Leicester, I have been so impressed over every single day how the doctors, nurses, and every other health care professional has stepped up to do what is right for our patients. I'm very pleased and honoured actually to be here with you this morning, just to welcome you all to this inaugural virtual conference. Raghavan, as our lead for ophthalmology, and others have done a fantastic job in putting the program together. It's a very impressive program, I must say. And on behalf of the University Hospitals of Leicester, I'm delighted to be able to say that we're pleased to be a part of this truly international conference, and I hope you have a fantastic conference and a fantastic day. I'm afraid I'm not an oculoplastic ophthalmologist. I don't really necessarily know very much about it. Raghavan tries to teach me about it every time we meet, and I've slowly started to learn. I have to say I'm a pediatrician by training myself, and it's another story as to how I got involved with being clinical director for a bunch of surgeons. But it's been a true pleasure of mine to lead them over the last few years. Anyway, enough of that. I'd just like to sort of welcome you all to this conference. I think it's very impressive, and I think it also, for me, sets the scene for how we could be managing conferences and developing conferences on an international scale going forward around the world. And I look forward to having a very successful meeting day. Thank you very much, Raghavan.
Thank you. Sendil, can you please?
Yeah. Thank you, Dr. Andrew. And at the outset, I'd like to welcome you all to our meeting today. And at the outset, I'd like to thank Dr. Raghavan Sampath, who is the brain behind this meeting, who in these difficult times and in the midst of his extremely busy schedule has succeeded in putting this excellent program together. And he deserves a big hand. With these few words, I would like to invite Dr. TSS, who's the medical director of Shankar Nethralaya, who will speak to us a few words and bless this meeting.
I'm going to call TSS on the line now. Can you just wait on the line, Sandil, for a minute?
Sure, sir. Sure.
Yes, Morgan.
Please just talk, sir.
Okay.
Dr. TSS online.
Okay. Good morning, UK. Good afternoon, India. Good evening, Singapore. I have proud privilege in inaugurating this wonderful global close in spite of COVID outbreak. We have had a Ophthalmological Society midterm just last week where 2,500 people attended. And I'm sure that your oculoplasty workshop will have more people to be listening to this. And I am grateful to our team from Shankar Nethralaya, Dr. Bipasha, who is the director, and they see about 25,000 patients a year and perform 3,000 operations a year. And with these few words, I have great pleasure in inaugurating this course. And thanks to Raghavan Sampath, Mohan, Gangadhar Sundar, all my friends, Santosh, Shanover, etc. Wishing the conference all success. Thank you. I'm sorry that I'm not able to come on the video. God bless. Thank you.
Thank you, sir. Thank you. Thank you very much, sir. And now I'd like to invite Professor Dr. Mohan Rajan, who's the chairman and medical director of Rajanekar Hospital, Chennai, India. He is a teacher of mine and is a great supporter of all oculoplastic meetings in India. And he is a big backbone of all our endeavors to promote oculoplastics in India. With this, I'd like to welcome Dr. Mohan Rajan, sir, to speak a few words to us.
Namaste to all. Good morning to people in the UK. Good afternoon to people in India, and good evening to people in the Singapore. Let me at the outset thank Dr. Raghavan Sampath for this fantastic initiative. Last month, we had a Indo-UK teaching program, which was a grand success as well. I'm sure, and this program also, which is the international webinar on oculoplasty, lid, lacrimal, and orbit, it's going to be a huge success as well. It's not an easy task to coordinate the top institutes from UK, including Leicester, Coventry, Manchester, Moorfields, and other centers as well, and top centers in India from Chennai, Delhi, Hyderabad, Bangalore, Guwahati, and so many other places, the top institutes in India as well. Of course, from Singapore also. I think, in my opinion, Raghavan Sampath, who visitor consultant at Rajanekar in Chennai, is a phenomenon by himself. Because only a person like of his caliber can do such things, coordinating such very difficult task, coordinating all the major institutes and bringing them on a single platform, on a virtual platform like this, which is very, very important today, in today's scenario, when all of us are going through the very tough COVID pandemic. I wish the function, the program, all the very best, and I'm sure it'll be of use to all the practicing ophthalmologists as well as for the residents as well. Thank you once again for the wonderful opportunity.
Thank you, sir. With this, we shall start the meeting, and the first session will be chaired by Dr. Santosh Shanavar, who heads the Department of Oculoplastics at Center for Sight at Hyderabad. He is a leading figure in the field of ocular oncology throughout the world, and he will be accompanied by Professor Ashok Grover, who is the chairman and medical director of Vision Eye Center in Delhi and heads the Department of Ophthalmology at Sir Gangaram Hospitals in New Delhi. I welcome both of you to chair this session and take over, sir. Dr. Santosh and Professor Grover, please.
Thank you, Senthil. Santosh, can I see you?
Yeah, I'm here, sir. You can start off.
Okay. So I welcome you all to this wonderful opportunity to interact with colleagues in Singapore and UK. And it's wonderful to be co-chairing this session with Santosh. We have some very interesting cases lined up, and we will start with the first one, which is a case by Dr. Nandini Botra from LV Prasad Institute. And she'll start her presentation now. May I request Dr. Nandini, please?
Yes, sir. So am I audible?
Yep.
Yeah.
Yep.
Yeah, so I'll just share my screen and probably we'll start from there. Yeah, is my screen visible?
It is.
Yep.
Yes. So firstly, good evening, good morning, good afternoon to people at respective places. Firstly, I would like to thank Dr. Raghavan and Dr. Senthil for giving me this opportunity. Now, today, the case that I'm going to present is a very interesting case, has a very interesting history. So this 35-year-old gentleman, presented to us with this swelling in the medial canthal area and the lower eyelid, extending almost to the half of the lower eyelid. And what we see here is an external scar, which indicates that there was a previous history of some lacrimal surgery or some surgery which had taken place in that area. So on inquiring the history, this patient had a history which dated back to almost 12 to 13 years when he first complained of watering. It was way back in 2006 when he underwent some lacrimal sac surgery. However, the documentation was not available with him. He was okay for a few months, and then there was a progressive increase in this swelling on the medial canthus as well as progressive increase in the epiphora over years. And in 2017, he presented at another clinic with increased swelling and watering. Now there, they asked for an MRI looking at the swelling, and this is what they saw on the MRI in December 2017. So if we closely look at these pictures, on MRI, we see in the top two pictures in the coronal cuts, T2 images, we see a well-defined mass with a variegated appearance in the lacrimal sac fossa and the bony nasolacrimal duct area with minimal extension into the anteromedial orbit here. And in the T1 cuts, we see an iso-intense lesion in the region of the lacrimal sac fossa with very minimal extension into the anteromedial orbit. Now, they diagnosed this to be a lacrimal sac abscess with a perisac abscess, and they subjected the patient to a revision DCR along with intubation and mitomycin C. Now, during the course of the DCR surgery, they noticed a small mass in the lacrimal sac, which was sent for histopathology, and it turned out to be a solitary fibrous tumor. However, no further intervention was done. Now, 1 year later, post the DCR surgery, which was done elsewhere, the patient presented to us with an increased swelling, and we asked for a CT scan imaging of the orbit. And this was the CT scan picture. So on the bone windows, we see that, So on the bone windows, we see that this was the pre-existing ostium, and we see that there is a extension of the bony, there is widening of the bony NLD and a sort of soft tissue mass in the area of the lacrimal sac and the bony NLD region, slightly extending into the middle meatus of the nose. On further cuts, we see that the bony NLD is expanded along the entire length with the mass almost reaching up till the inferior meatus. So we went ahead and we did a nasal endoscopic examination. This was the external scar from the previous surgery. Now this is the mass, this is the middle turbinate. Anterior to the axilla of the middle turbinate, we see a large reddish pink lesion with feeder vessels right in front of the axilla of the middle turbinate. And this was corroborating with the previous dactylocystorhinostomy ostium. On medializing the inferior turbinate, we see a reddish pink lesion coming into the inferior meatus with a widened nasolacrimal duct orifice. So on seeing this mass and with the history that they had excised a previous mass from the lacrimal sac region, which turned out to be a solitary fibrous tumor, considering the history, which was a long duration, and the history of recurrences, we probably thought that this is an aggressive tumor and decided to go ahead with an external as well as endoscopic approach to remove the tumor entirely. So we took an incision along the previously existing DCR scar, and we separated the mass from all the sides. Now here what we see is the orbital part of the lesion, which was well demarcated and separated from the soft tissue as well as the bony components. Now this is the external, this is from the external side. This mass was then entirely removed. As you see, we've taken a 4 millimeter normal tissue along with it to get a margin clearance. Now we've excised that tissue, and what we see is the clear nasal cavity from here, and this is the middle turbinate. Now the same thing when we view from the nose via the endoscope, this is the middle turbinate, and the anterior to the axilla of the middle turbinate is the huge cavity now after removing the tumor. Now this was the orbital part which was excised completely. What we see here is the dilated nasolacrimal duct. Now it is important to remove this tumor completely from the nasolacrimal duct if we want to achieve complete tumor clearance. So we went ahead with a lens spatula around the lesion to see whether it is separate from all the bony orifices. And once we separated that, we just pulled out this lesion using a suction and a blunt forceps from the nasolacrimal duct. So it was still attached to a small part on the external side of the lacrimal sac fossa. But what we see here is a completely dilated nasolacrimal duct, and the bony surfaces are intact with no extension or destruction of the bony orifice. This is the inferior meatus, which we see from the external side. Now the tumor is still attached on a small part of the lacrimal sac fossa, which we will now excise, taking about 4 millimeter of the normal tissue along with it to get margin clearance. Yes. So here we are excising the residual mass lesion. And this was the tumor removed from the orbit and the nasolacrimal duct. On viewing endoscopically in the inferior meatus, we see that the entire mass has been removed and there is no residual lesion in the inferior meatus. Now this mass was then sent for histopathology and was confirmed to be a solitary fibrous tumor. The Ki index or the mitosis rate was very low. However, keeping in mind that the duration was very long and there were recurrences in the past, we got the patient to undergo external beam radiotherapy. 8 months following this external beam radiotherapy, the patient is still doing fine without any recurrence externally or radiologically. Thank you.
Right. Unfortunately, there's no time for discussion. The point was doing 5 minutes presentation and 5 minutes for discussion. Following each presentation is what was decided by the panelists this morning. Yes, I'll leave it to the chairs now. Thank you.
Santosh, one single comment before you announce the next one.
I think it was a very well managed situation. SFT is a benign lesion, but it is locally aggressive. And hence the decision to give stereotactic radiation or any sort of radiation would help at least lower the chance of local tumor recurrence. Although margins are clear, we know that it is a microscopically infiltrative lesion, and the margins are never going to be so clear that there are no cells left, even if we take 4 or 6 millimeter. So decision to radiation is a good decision, I believe.
Thank you, Santosh. We will request all the speakers to please stick to 5 minutes so that we can have a discussion with all the cases.
Can I just ask one question to Nandini?
Sure.
Yes, sir.
Yeah, I just want to know why when they took the biopsy in the first instance or the second surgery, why they didn't do anything for the fibrous tumor?
So that was done elsewhere, actually. The patient presented to us 1 year later. So he just carried the report of histopathology with him. That is how we knew that it was a solitary fibrous tumor. They just did a revision DCR surgery at that time.
They did a biopsy also, no? You said.
Yes. They found a small mass lesion. That was what was written in the notes, and which was sent for histopathology, came out to be solitary fibrous tumor. However, no intervention was done further.
Thank you. So it's tumor season. Another tumor from Shankar Netralaya, Dr. Shebin. Please start your presentation.
Shebin, you're not audible.
Audible. Yeah.
You'll have to unmute yourself. Shebin?
Yes, sir.
Yes.
Am I audible now?
Yes.
Yeah.
Okay. Coming to case of primary orbital alveolar soft part sarcoma presenting as a vascular neoplasm. A 13-year-old boy presented to us with a history of prominence of the left eye since past 5 years, which was gradually increasing in size and was painless, with a rapid increase in size and diminution of vision since past 3 months. Elsewhere, he was diagnosed as a case of orbital angioma and he came for further management. On examination, his best corrected visual acuity was 6/24 N6 in the left eye with a relative afferent pupillary defect. Ocular movements were restricted on elevation and adduction. He had an 8 millimeter proptosis with outward and downward displacement of the globe. We could see dilated vessels on the medial bulbar conjunctiva, and rest of his anterior segment examination was within normal limit. Posterior segment examination revealed an edematous optic disc. VEP showed grossly reduced amplitude on the left eye. On MRA, there was a well-defined intermediate signal intensity lesion situated in the medial orbit of the left eye, which was extending into the apex and causing optic nerve compression. There were multiple dilated blood vessels and flowers could be seen, suggestive of a vascular tumor, possibly hemangiopericytoma. After consultation with our intervention radiologist, planned to go ahead with embolization followed by excision biopsy was made. Embolization was done using 25% NPCA glue through percutaneous route after doing a lateral canthotomy. This is the pre-embolization digital subtraction angiography showing the highly vascular tumor which is supplied by the ophthalmic artery. A short video showing the completion of the embolization procedure. And this is the post-embolization angiogram showing the complete obliteration of the tumor. His visual acuity dropped into perception of life after embolization, and on fundus examination, it revealed a coeloretinal artery occlusion. But in spite of maximal medical treatment, the vision could not be improved. He underwent excision biopsy 1 week post-embolization by a transcaruncular approach. Intraoperatively, we found the middle rectus muscle could not be separated from the mass, hence was sacrificed. The mass with the glue in situ was removed in parts. Histopathology examination revealed polygonal cells which are arranged in an alveolar pattern with fast positive granules suggestive of alveolar soft part sarcoma. Immunohistochemistry was positive for TFE3 and negative for myogenin, smooth muscle actin, and vimentin, confirming the diagnosis. A PET scan revealed ill-defined, mildly metabolically active soft tissue on the orbital apex, suggestive of residual disease, but there was no evidence of metastasis. In conjunction with our pediatric oncologist, a tumor board review was sought and planned for adjuvant external beam radiotherapy of 60 gray over 30 fractions. At follow-up MRI and PET CT at 7 months showed very minimal soft tissue at the orbital apex, but there was no evidence of recurrence or any metastasis. This is how it presented to us, and at 7-month follow-up after completion of the radiotherapy, this was how. But the vision was still perception of light. ASPS, the term was coined by Christopherson et al. In 1952. It comprises 0.5 to 0.9% of the soft tissue sarcomas. In adults, it commonly occurs in extremities, but in children, the most common location is orbit and tongue. The unbalanced translocation between 17q25 and XP11.2 result in a chimeric fusion protein ASPS-CR1-TFE3. The identification of the same in immunohistochemistry is diagnostic of ASPS. Orbital ASPS is more common in children and adolescents. Orbital location helps in early detection. Presentation is often non-specific with abaxial proptosis. CT reveals hyperdense lesion with heterogeneous contrast enhancement. MRI reveals this characteristic flowood suggestive of high vascularity. The high vascularity often camouflages as vascular lesion with possible differentials of lymphangioma, hemangioma, or hemangiopericytoma. There are various other morphologically similar tumor, especially alveolar rhabdomyosarcoma. Histopathology shows a characteristic alveolar pattern, and these tumors show low mitotic activity and Ka 67%. Younger age and tumor size less than 5 cm are good prognostic factors, while metastasis at presentation and incomplete surgical excision leads to bad prognosis. Even though metastasis can occur in up to 79% of patients, if managed appropriately, the 5-year survival rate can be prolonged up to 88%. Complete surgical excision followed by postoperative radiotherapy is the treatment of choice. Since it is highly vascular, preoperative embolization helps in complete surgical removal. In literature, we found only one case of orbital ASPS which was managed with preoperative embolization followed by surgery. We are presenting the second case which was managed in a similar way. The ASPS, they show poor response to conventional chemotherapies. Tyrosine kinase inhibitors and anti-angiogenic factors are the new promising treatment options. In conclusion, orbital ASPS is a very rare tumor. Immunohistochemistry is diagnostic. Complete surgical excision offers a better prognosis as these tumors are resistant to conventional chemotherapeutic agents. Owing to its high vascularity, preoperative embolization will help in complete surgical removal. Long-term follow-up is recommended as it can metastasis at any point of time. Thank you.
Thank you, Shemin, for a nice presentation and a nice management. Any questions from the panelists or audience? Santosh, would you like to comment on the management?
Well, ASPS is a surgical disease. The most important aspect is to completely remove it without a piecemeal resection. In this case, what I saw was that, of course, embolization was done to reduce vascularity, but the resection was piecemeal. It wasn't resected as a single mass. So whenever we have a malignant lesion or a suspected malignant lesion or a potentially malignant lesion, the approach can be larger. Instead of transcarencular, transcutaneous approach with a larger axis and a better visualization would help in near complete removal of the lesion, which would minimize the risk of local tumor recurrence. And embolization is not always mandatory in all lesions that are highly vascular. You can possibly get away with hypotensive anesthesia with complete excision as well. So embolization in this patient has resulted in a complication. So I would not do embolization in every patient where the lesion is slightly more vascular than usual.
Okay,
So
sir.
Santosh, Vipasha wants to know what approach would you have chosen?
What approach for surgery? Transcutaneous.
For this patient, yeah.
Transcutaneous would be a better approach. And we know that from the review of literature, of course, there are not many patients of ASPS, but we know that it is a tumor, although it doesn't embryologically arise from an extraocular muscle. It is very closely associated with an extraocular muscle, and movement restriction is a feature. Whereas with hemangiopericytoma, which is the MRI differential diagnosis of ASPS because of flow words which mimic each other, ocular motility restriction is generally not a feature, and hemangiopericytoma is not a tumor of children and young adults. ASPS is a tumor of children and young adults. So very well circumscribed lesion with flow words in a child, I would put my bet on ASPS rather than hemangiopericytoma.
Okay. Noted, sir.
Would Jeff Rose like to speak out his comment, please? Jeff? Could you unmute yourself and give your comment that you have put on the chat?
David is also here.
Okay. So Jeff, if he's not unmuted himself, I'll read out what he says. The embolization was quite effective.
Jeff Rose, please.
Yeah. His comment is that the embolization was quite effective here. Otherwise, the surgery for ASPS is really difficult because of vascularity. So if maybe then we can move on to the next case. Santosh, can you announce the next one?
The third case is by Dr. Neha Chandrakar of Gangaram Hospital with Dr. Ashok Grover, a misleading mass and unusual presentation of dural CCF with an intraorbital mass.
Hello, everyone. Am I audible?
Yeah.
Go ahead.
Yeah. Good morning and good afternoon to all. I'm just sharing my screen. Yeah.
Go on.
So today I am presenting a case of a misleading mass of a 19-year-old female who presented with gradually progressive proptosis and chemosis of right eye since 2 months, which was preceded by an incident of sudden onset headache and right orbital pain 2 months back. There was no history of trauma. There was no history of fever. She was a non-hypertensive. She was diagnosed with non-specific orbital inflammation elsewhere, for which she received intravenous methylprednisolone followed by a course of oral prednisolone in tapering dose, with which no response was noted. On presentation, we recorded visual acuity to be 6.6 for distance and N6 for near in both the eyes. Pupillary reaction were normal in both the eyes. Fundus examination was normal with no evidence of disc edema or pallor in either eyes. The positive findings noted were axial proptosis of 7 mm in the right eye, which on Hertels was recorded as 28 and 21 in right and left eye respectively, with bar at 110. There was no palpable mass. Retropulsion there was no increase in resistance on retropulsion. There was no pulsation or bruit that could be felt or heard. Valsalva maneuver was negative. Ocular motility was severely restricted in all the gazes in right eye and was full and free in the left eye. There were no lid signs such as lid retraction or lid lag were absent. There was diffuse mild conjunctival congestion and chemosis in the right eye with episcleral congestion present. The intraocular pressure was 21 and 14 mmHg in right and left eye respectively. So on the basis of the clinical findings, the differential diagnosis at this point were vascular lesion or an AV fistula. It could be a non-specific orbital inflammation or an orbital mass or a tumor, or it could be a thyroid orbitopathy. So we went ahead with MRI. On MRI, in this T2 axial scan, we can see the hyperintense heterogeneous intraconal as well as extraconal mass that is leading to right proptosis. Also, we can see there are multiple areas of signal void seen, which is causing heterogeneity. In this T2 sagittal cut, we can see the hyperintense multi-layered heterogeneous mass here, which is with well-defined borders that is present inferiorly in the orbit. With contrast, there is a large hyperintense area of dilated veins with an area of delayed enhancement within. That is probably a thrombus resulting in displacement of muscle. Here we can very well appreciate the dilated superior ophthalmic vein in this axial cut. And also right-sided cavernous sinus appears to be bulky with early filling. So after this scan, we were pretty much sure that it's a vascular lesion. And so is it a cavernous hemangioma? Let's look at the scan again. So this well-encapsulated intraorbital mass may look like a cavernous hemangioma, but here we have this dilatation of superior ophthalmic vein and thrombus within the mass that was appreciated post-contrast, which is not associated with cavernous hemangioma. So we can rule it out. Now what we are left with is AV fistula, So we had the provisional diagnosis of arteriovenous fistula, and then we went ahead with digital subtraction cerebral angiography to confirm the diagnosis, where we can see the right external carotid artery lateral view, which shows an orbital apex and anterior cavernous sinus dural AV fistula, which are getting feeders from accessory meningeal, middle meningeal artery, and branches of the internal maxillary artery. Also, branches were seen from the dural branches of cavernous internal carotid artery. I'll just show you the video, a short video of this DSA. So here we can see that this fistula here is draining into this irregularly lobulated venous pouch in the orbit, which is draining anteriorly into the dilated and tortuous superior ophthalmic vein, and finally via the facial vein into internal jugular vein. So we had the final diagnosis of internal carotid cavernous fistula type D, as it was getting branches from both the dural branches of ICA and ECA with secondary orbital varix with partial thrombosis. She was then referred to our interventional neuroradiologist, who performed endovascular embolization in this patient via transarterial route using liquid emboli, following which significant obliteration and slowing of the fistula was observed. So now this was the picture 10 days post embolization, where we can very well note the difference in decrease in proptosis and decreased episcleral and conjunctival congestion and chemosis. This was the picture 3 months post procedure, where we can see that the patient was completely asymptomatic with complete resolution of proptosis and congestion. So coming on to a small discussion about this case. As we all know that in CCF, because of the resistance from the retrograde venous flow into the ophthalmic vein, it leads to these features. And in direct CCF, the features are quite prominent, whereas in indirect CCF, the features are similar but less severe and chronic in nature. And also the absence of orbital bruit or pulsation doesn't rule out a CCF. Many a times it is not seen in indirect ones. And hence absence of such classical signs can sometimes mislead towards a wrong diagnosis, as in this patient also, where she was earlier misdiagnosed as pseudotumor elsewhere. Since this was a low flow fistula and hence more prone to the development of venous thrombosis because of stagnant blood flow. But here in this case, the thrombosis was quite unusual, which at a glance appeared like a large intraorbital mass diffusely involving the intraorbital space, leading to proptosis, probably due to which it was misinterpreted earlier as pseudotumor. But when we closely look at all the other signs, it all points us towards an AV fistula. And in such cases, MRI is preferred as it offers advantages of detecting flow voids as well as orbital edema. Digital subtraction cerebral angiography is the gold standard for definitive diagnosis to locate and grade the fistula, to determine the anomalous flow, and in planning its endovascular management approach. And when we go for Doppler ultrasound, what we get to see is arterialized ophthalmic vein. When it comes to management, direct fistulas almost always need intervention, whereas indirect fistulas often resolve spontaneously and do not require treatment. Whereas there are few indications where indirect ones need intervention. These are the few, and in this case, the indication was severe proptosis here. So endovascular embolization, either transarterial or transvenous, is the first-line treatment modality for most CCF, as it is seen that over 90% of the patients can be cured successfully in this manner. In this case, transarterial approach was taken. Various embolic agents such as balloon, glue, liquid emboli, coil or mesh can be used. Balloon are usually used in larger fistulas. Here, liquid emboli was used as it best fills the smaller feeders. Superior ophthalmic vein approach and neurosurgical approaches remain an option in unsuccessful or impossible cases. So the take-home message here is the unusual presentation of indirect CCF with such an intraorbital mass. Whenever there is no response with steroid therapy, we should always look for vascular cause. An absence of pulsation or bruit or negative Valsalva maneuver doesn't rule out a vascular lesion. A CT or MRI scan isn't sufficient in such cases. Cerebral angiography is confirmatory. We should always look for the root of the cause and treat it, as sometimes superficial picture becomes so obvious and deceiving that its origin is camouflaged. Check angiography should be done in such cases after 3 to 6 months, as there are chances of recurrence or residual fistula that wasn't completely occluded after the procedure. Thank you so much.
Thank you, Neha. Any comments?
Can I butt in for 1 minute? It's a great pleasure and honor to have Jeff Rose online. Jeff, you should be able to unmute yourself.
Yeah, I'm here, Ron. Thanks very much for the welcome. Interesting session, and thanks for organizing it.
Very, very kind of you to be on. And
it's a pleasure. Thank you.
Great honor to you have Jeff.
It's a pleasure to be here. The last case, I was just wondering, could I make a comment? Is that all right, Ashok?
Yes, absolutely.
Looking forward to it.
I just wonder whether this lady originally had a venous anomaly in the orbit, which then became arterialized, because the amount of expansion of that localized vascular lesion is really quite marked. And I suspect she had an underlying abnormality, which then became very evident once it arterialized.
Could very well be. Yeah, that's a very, very good comment. So would that make a difference to our management in any way?
No, I think the management was perfect. You know, a beautiful illustration of, the way it should be managed. They're very difficult, and they, of course, may be a future problem. And the indication of whether there's underlying venous anomaly is often that there will be abnormal areas of brain, so that you'll get things like, cysts within the head, maldeveloped middle cranial fossa, and so on, as an underlying abnormality. So it's a sort of hint that there was a previous problem, but it was beautifully presented. Thank you.
Thanks, Jeff. Maybe go on to the next one, Santosh.
Yes, sir. Next would be by Dr. Anila from Arvind Eye Care System. We don't know what the case is, but is Anila here? Yeah, go ahead.
Yes, sir. Are you able to see my presentation, sir?
Yes, we are.
Thank you.
Good afternoon, everyone. I'm Dr. Anila, Fellow Orbit and Oculoplasty from Aravind Eye Hospital, Madurai. And today I'm going to present about the case of Great Masquerader. This is a case of a 57-year-old male who presented to us with bilateral progressive protrusion of eye since the last 5 years, associated with progressive loss of vision in right eye. He has given us a history of loss of appetite and weight since the last 1 year. He is a known case of supraventricular tachycardia with pericardial effusion, diagnosed in 2009, and he has then deferred complete evaluation and is on homeopathic medication. Coming to clinical examination, his best corrected visual acuity in right eye is no perception of light, and left eye is 6/18. Lid showed fullness more in lower lid than upper lid, and also temporally. Associated with severe chemosis with congestion and in superior and inferior temporal mass, and pupil showed relative efferent pupillary defect in right eye and reacting to light in left eye. There is -4 restriction of limitation of movements in all gazes in right eye and -2 limitation in left eye. There is a superior dystropia with non-tender, firm superior and inferior temporal mass palpable with no possible finger insinuation between mass and the globe. And there is left eye mild superior dystropia with non-tender firm mass inferior temporally with normal finger insinuation. Fundus examination in right eye revealed secondary optic atrophy and left eye was normal. On systemic examination, we were able to palpate multiple cervical lymph nodes on both sides of the neck. A CT scan revealed diffuse mixed density lesion of intraconal and extraconal space of both orbits, right more than left, encasing the optic nerve, extraocular muscles with a possibility of orbital inflammatory disease and lymphoproliferative disorder. At this point, we have kept in mind 3 differential diagnoses: orbital inflammatory disease, a lymphoproliferative disorder, and orbital tuberculosis, since the patient had endemic. So we went ahead with an incisional biopsy. An incision and the histopathology picture showed fibrocollagenous tissue with diffuse infiltrated inflammatory cells with polymorphic population of lymphocytes and plasma cells. And we did a immunohistochemistry for CD20 to rule out lymphoma in this patient, which is scattered positive. And the ancillary investigations included lymphocytosis and elevated ESR in this patient, and a workup of systemic tuberculosis with chest radiograph and sputum examination was done, and it revealed no positivity for tuberculosis. But the tissue PCR for Mycobacterium tuberculosis and MAN2 text came out to be positive. The PCR target gene for Mycobacterium tuberculosis, MPB64, was amplified in this patient in nested PCR. So we came to a diagnosis of bilateral extrapulmonary tuberculosis of the orbit, and we started the patient on 9-month course of anti-tuberculous treatment along with tapering doses of steroid. After 9-month treatment, the clinical picture is like this, and the patient is comfortable. Coming to a second case, it is a case of 47-year-old male who had complete loss of vision in the right eye since 6 months associated with watering and discharge. And we advised him radiological investigations, and after 1 month, this is the presentation, and CT scan showed complete destruction of preceptal and postseptal soft tissue of the orbit. And we went ahead with incisional biopsy, which came out to be orbital inflammation. And again, in this patient also, we did a PCR, and nested PCR came out to be positive for Mycobacterium tuberculosis. We have given him a 9-month treatment of antibiotic anti-tuberculosis therapy with tapering doses of steroid. ATT included 2 months of isoniazid, rifampin, ethambutol, and pyrazinamide, followed by 7 months of isoniazid and rifampin. Coming to discussion, orbital tuberculosis secondary orbital tuberculosis is more common than the primary, where secondary includes infection of ocular region through hematogenous route from a distant site or extension of neighboring structures. And primary is infection of the ocular region with localized symptoms without systemic involvement. Coming to classification, it is classified as classical periostitis with discharging sinuses and ulceration, orbital soft tissue tuberculoma or cold abscess without bony destruction, orbital tuberculosis with bony involvement, orbital tuberculosis that can spread from the paranasal sinuses, and tuberculous dacryoadenitis with involvement of lacrimal gland. A diagnosis of orbital tuberculosis as suspected by histopathological examination must be confirmed by the demonstration of mycobacterial DNA by polymerase chain reaction. In adults, it is necessary to differentiate orbital tuberculosis from inflammatory disease of the orbit and lymphoma. The differentiating points are: in a lymphoproliferative disorder, it is usually unilateral with insidious onset and not associated with pain, and is associated with symptoms of fatigue and malaise and other constitutional symptoms. Blood picture usually shows anemia with elevated LDH levels, and immunohistochemistry shows CD20 positivity. Coming to inflammatory disease of orbit, which is usually a diagnosis of exclusion, it presents unilaterally with acute onset associated with pain, and anatomical location is variable with very minimal constitutional symptoms. So, in patients with no obvious clinical symptoms, periorbital masses are often misdiagnosed as inflammatory lesions of the orbit. Hence, it is important to rule out orbital tuberculosis, especially in endemic areas, before starting the patient on steroid therapy. This I conclude my presentation. Thank you for giving me this opportunity.
Thank you, Anila. You really have a wealth of cases in Arvind Eye Care, and these are unusual cases. We do see tubercular periostitis much more frequently, but these kind of cases are fairly unusual. I would invite comments from any of the panelists on whether they've seen similar cases.
Yeah, Ashok, I think the giveaway was very early in case one. It was a beautifully illustrated case, but the giveaway was the pericardial effusion occurring in 2009. You don't get pericardial effusions along with SVT. You know, the SVT we can all have if we have a bit too wild a time, but a pericardial effusion is tuberculous until proven otherwise, particularly I would think, you know, in India and, you know, places where the prevalence is higher. I feel like Daniel entering the lion's den talking about TB, because you guys know so much more about it. But, you know, the giveaway was there. As soon as it came out in the history, it was brilliantly presented.
Yeah, it's not that usual. Yeah.
No,
The
but
patient at that time deferred complete evaluation, sir, and he is taking homeopathic medication. So we were not able to arrive at a conclusive diagnosis that this is tuberculosis.
no, sure. And interestingly, a chest X-ray was clear, was it, on the first case?
Dr. Usha Kim, would you like to add something?
I think this was again a very difficult scenario, but the sequence of events, as Dr. Rose was mentioning, the pericardial effusion was the giveaway. And that's when we jumped ahead and went and did the incisional biopsy, which did not give us a big clue. But then the PCR was conclusive, and then we treated the patients with ATT. Both the cases were almost very similar, except the first case talking about the pericardial effusion was the giveaway point.
Thank you. Yeah.
Thank you very much. I think
it was a lovely case.
Yeah.
Thank you.
Tuberculosis masquerade in so many other ways. We now go on to the next case by Dr. Arjun Durairaj from Rajan Eye Care, who presents a case of treating a wide-eyed pediatric blowout fracture. Dr. Arjun, please.
Yes, sir. Good afternoon, everybody, and thanks a lot for giving me the opportunity to present in this prestigious meet. I'm here to present. Can you see my screen?
Yes, sir.
Yeah, I'm here to present a case of a 13-year-old male who actually came with a history of punch on his face 1 day ago, and he complains of double vision, and he had nausea and vomiting as well. On examination, his eyes were he presented with a white eye, with restriction of abduction and adduction of his left eye, with normal elevation and depression, with his anti-segment big normal, pupils were normal, fundus examination was normal, his vision was 6, 6, and 6. His pulse rate was 58 per minute. And on investigation, we had just done diplopia charting just to document the amount of restriction in his left eye for his abduction and adduction. His FD forced duction test was positive. We had done his blood profile, coagulation profile, and here comes the main investigation of choice, that is the CT scan. CT scan orbit, the axial view and the coronal view was done, and here we could see the fracture of the medial wall with the entrapped medial rectus here in axial view as well as in the coronal view. So we had come to a diagnosis of pediatric medial blowout fracture, which was a white eye fracture. So the plan of management was surgical release of the entrapped medial rectus muscle and to place a bio-reabsorbable implant where we used osteomesh in this case under GA. And it was done through the transcaruncular approach. And here's a short video on the operation. So we had incised using a Westcott scissors between the plica and the caruncle, and sharp dissection was done to reach the medial wall just behind the posterior sulcus. And with the periosteal elevator, we elevated the periosteum and reached the fracture site, and we had released all the incarcerated medial rectus, and we had used an osteomesh. So here we are fashioning the osteomesh to bridge the fracture site. And this osteomesh implant was placed at the fracture site. So this is a transcaruncular approach which we use to correct the medial wall fracture. And here's the short video comparing the pre-op and the post-op. So pre-op where he had a restriction of abduction and adduction of his left eye. And this post-op where he is having full extraocular motility with no complaints of diplopia. So this is a case of pediatric white eye broad fractures. A few points on the pediatric broad fracture. They can occur even after common trivial injury. They can present as white eye. Systemically, they can present with nausea, vomiting, and bradycardia due to oculocardiac reflex. An examination of the extraocular muscles is very important, has to be done very carefully. Trapdoor type of entrapment of the extraocular muscles is very common due to the elasticity of the bones. So CT scan is the imaging of choice. And this condition is actually an ocular emergency where we'll have to intervene surgically and release the muscle entrapped within 24 hours to 48 hours to prevent the ischemic necrosis of the muscle. And as always, the transconjunctival approach is, in case of small fractures, we can use a bioreabsorbable implant. Thank you.
Thank you, Dr. Arjun. That was very well presented. So this is one of those fractures which can be an emergency, but this patient did not have any systemic features, right?
The pulse was around 55.
Yeah, he had the nausea. He had the nausea and vomiting.
Okay.
I would say, Ashok, although it's said always to take the muscle out, and the muscle was well, prolapsed right through the fracture over quite a lot of its length. Interestingly, I had a case of where it had been through a fracture for about 15 months and nobody had dealt with it. And I released it and it was completely out into the sinus. I released it and the muscle looked dreadful. I really thought this has got no chance of working at all. And yet the child picked up about 95% of the range of motility after a few months. In other words, although the muscle looked dreadful, there was still enough there to keep it working. So if you see it late, it's not without hope, but I agree that you don't want to leave them because it may otherwise undergo necrosis, but it's not inevitable.
Nature has healing powers beyond our imagination.
Yeah,
I agree.
Can I make a comment?
Yes, Mohan, please.
Yeah, this patient had systemic symptoms as well.
Yeah,
Patient
right.
nausea, vomiting, and bradycardia because of the oculocardiac reflex. I just wanted to ask the panelists as well as Jeff as well, how early you will operate on these patients?
I think if they have persistent symptoms and such marked restriction, they've got no chance of recovering. But occasionally they have quite good motility, but still some nausea that persists. And in those, I'll consider exploration later on, and it can get rid of that symptom. But, they're allowed a day or two, but probably not much more.
True.
1 or 2 days, okay.
Thank you very much.
What's interesting is how often do you see the medial blowout fractures? Here you would typically see white eye with floor fractures, except in our West Indian population, where medial blowouts are much commoner than floor blowouts. They have a much tougher orbital floor.
We don't see many. I've only seen one. We see many more of the floor, right? That's true.
Yeah, so very similar to us. But West Indian, as I say, they have a much tougher orbital floor and they typically will blow out medial.
Okay.
Thank you very much for all your comments. And there are some questions on the chat and question and answer. Since we are running a little bit behind schedule, we have loads of time to discuss and we will bring up some of these questions later. It's a great pleasure to invite Chandramouli from Wolverhampton, my oculoplastic colleague in the United Kingdom, and Tristan Ruza from Birmingham, my orbital colleague as part of MOPS and BOPS. Thank you both for taking over the next session, please.
Thank you. Tristan, you want to start?
Many thanks, India, for your contribution, much of which was very unusual. But we have a few unusual cases in the UK as well, and I'm sure we can beat you, possibly. Antonella from Leicester, would you like to start this session, please?
Yeah, Ian is going to present now. Yep.
Ian, you're on.
Hello, everyone. Can everyone hear me?
Yes, you're on.
Hello.
Yeah.
Hi, my name's Ian De Silva. I'm one of the oculoplastic fellows at Leicester Royal Infirmary. And I've got an interesting case of a young boy who presented with a bump on the head. So I'll begin that in a moment. Put my slideshow on. There we are. So it's an 11-year boy who had a 5-week history of a recurrent swelling on the left side of his upper brow following an incident where he had when he was climbing from below a table and he hit his head in that area. He had 2 courses of antibiotics for the last 15 days. And even though it helped transiently, the swelling returned following the course of the antibiotics. His medical health includes asthma, but otherwise he's medically fit and well. So when we saw him, we saw that he had a firm swelling on the superior lateral aspect of the eyebrow with fullness. I've got a little picture of a patient. This is not the patient who we saw, but a very typical appearance of what the patient looked like. And you can see that on the left side, near the lash and the brow area, there is a little bit of fullness. In terms of his discomfort, he had a mild discomfort on upgaze, but there was no evidence of optic neuropathy. He had normal ocular movements and he had soft globes and retropulsion. Examination of his anterior segment and fundus was normal. So what was going through our minds? We were thinking, could this potentially be a ruptured dermoid cyst? Or maybe it's an unusual residual orbital cellulitis, as well as some of the other orbital diseases that we have to consider in these cases, as listed. He did have some blood tests done, which showed that he had normal inflammatory markers, normal white cells and CRPs, and the patient himself was very well. He had no fevers, and he felt he was his normal self. He had normal LFTs as well. So we proceeded to arrange an MRI scan, which was fortunately done on the same day. Now, the most striking feature you can appreciate from this is a soft tissue extracorneal mass centered on the superior lateral aspect of the orbit. There is intracranial extension into the anterior cranial fossa with marked dural enhancement. There was also bony destruction of the left frontal bone. There was downward displacement of the globe, and the lacrimal gland was seen separately and delineated separate to the mass. So the thought at this point was, could this be a primary malignancy with difference of lymphoma or Ewing's sarcoma? So we proceeded to do an anterior orbital biopsy, which was performed. And interestingly, it showed an extensive inflammatory infiltrate with eosinophils and multinuclear giant cells. The nuclei were described as curved in nature. Immunohistochemistry clinched the diagnosis as it showed positive S100 and CD1A, which are specific for Langerhans cell histocytosis. Electron microscope, should it have been done, may show something called Burbot granules. So a little overview about Langerhans cell histocytosis. It's a rare disease of myeloid cells. It affects 4 to 8 children per million and 1 to 2 adults per million each year. So it can affect any age. It has a wide spectrum of clinical presentation, with most being single lesions, and it's usually solitary bone lesions, but it can be a multi-system disorder, and we may have heard of some eponyms used in its name. So the bone lesions can be commonly found in the skull. Skin lesions can cause dry, scaly skin or erythematous lashes. Mucosal tissue can cause recurrent ulcerations of the gingiva. Lung lesions can cause pleuritic pain, shortness of breath, and the most devastating conditions can be central nervous system involvement, which can cause diabetes insipidus and progressive neurodegenerative symptoms. Our patient had the following workup. We did a full assessment to look for bony lumps, organomegaly, and lymphadenopathy. We had bloods to rule out liver disease and cytopenias. Urine osmolarity and water deprivation test was carried out to rule out diabetes insipidus, chest X-ray and imaging to rule out organomegaly. He didn't have bone marrow aspirate as his bloods were entirely normal. So in our patient, they had a solitary orbital lesion. So the treatment of this condition is primarily based on if it's a single system disease or a multi-system disease. In our case, he had a single system disease, which I'll go to in a moment. If only skin rashes are found, there is a thought that you could treat this by observation and they can resolve spontaneously. If localized bone lesions are found, surgical curettage can be performed, plus or minus radiotherapy, or even early chemotherapy if crucial bony lesions are found at certain anatomical sites. Multisystem disease will need treatment with chemotherapy with vinblistine and prednisolone, usually 6 to 12 months, but there's ongoing trials under the Histocytosis Society website, which is looking at what is the best duration of treatment for this. 6-week review is a good prognosis of indication. If they had a good response, then there's a 95% survival rate. If they had intermediate responses, 83%. If they had a poor response, it's 57%. Of course, not to forget treating the CNS involvement. And also nowadays, there's BRAF status will determine whether to use other personalized treatment. So finally, prognosis. Most cases have a good prognosis. In some studies, they showed over 95% survival rate, but in low risk, it's more than 99%. Risk organ involvement reduced this, and the risk organs we're talking about is liver, spleen, and bone marrow. If any of those are involved, then the survival rate was less. Lesions in the orbit, mastoid, and temporal bones are considered CNS risk lesions, which may develop into diabetes insipidus or the severe neurodegenerative conditions, which can cause the following. So our patient was found to have a CNS risk lesion due to orbital involvement, but it was single system disease. They were put on the clinical trial for stratum 1 group 2. They had an initial course of vinblastine and oral steroids, and they've actually had a very good response at 6 weeks. So we're very optimistic with this patient. So the learning points today: Langerhans cells is a rare disease of myeloid cells. It can present in many ways. There's a debate whether it's an inflammatory condition or neoplasm condition, although the evidence suggests that it is neoplastic in nature. Risk organs of poor outcome are spleen, liver, and bone marrow, and CNS disease risk organs are orbital involvement, temporal or mastoid bone involvement. Treatment, as we mentioned, depends on social or multisystem disease. Thank you very much.
Thanks, Ian. Very interesting case. In the interest of time, I'll allow one question or comment. Anybody? There's a question here about lesions disappearing by themselves. Any experience with this, Jeff?
Yeah, they certainly can regress spontaneously. And Jerry Harris, in Milwaukee has had a lot of interest in this, whether you should treat localized ones as potentially involuting lesions. But yeah, they can undergo it. And also at the time of surgery, when you curette them out, you can put in a bit of steroid. That seems possibly to reduce recurrence rates. But that destructive bone, if you saw that in an older person, you'd think extramedullary plasmacytoma. It's a very classic location in the upper outer quadrant. Or if there's a real history of trauma, something like cholesterol granuloma, expanding the bone and pushing out from it. But, in a young child, eosinophilic granuloma is your #1 choice, apart from maybe if you get other things, that are local to your area, like tuberculosis. I don't know if it affects the bone.
Thank you, Jeff.
Well, moving on, the next one is a double whammy from Coventry. And I would like to call upon Aman Sachdev to talk about his case first, please.
Hello, can everyone hear me? Can everyone see my screen? Wonderful. Okay, well, first of all, good morning, UK, good afternoon, India, good evening, Singapore. Thank you, Mr. Sampat and Dr. Senthil Nathan for the opportunity. This presentation is Help Me Doc, I can't get my specs on. So we start off with a 62-year-old female who presented to iCasualty. Her story is that in October 2019, she had episodes of black spots over her inferior bulbar conjunctiva, and she was able to wipe these away. So she assumed that they were due to just her mascara, just makeup. And then in mid-December, she woke up with a bleed from the eye. And she ultimately presented to iCasualty in the early new year. And her main presenting complaint was that I can't get my glasses on anymore. And I suppose that when she walked round into eye casualty, one could probably see why. So this is her appearance. You can see this extending from the right globe. And this is a zoomed in picture, and you can see that it's extending from the cornea. So I asked about this from her perspective recently, and in hindsight, she felt that because it was the festive period, she didn't necessarily want to come into hospital. Her husband was unfortunately ill last Christmas, and therefore she didn't want to risk coming into hospital and needing an admission or something. And she did say that she felt it would just fall off ultimately. But I think that the main reason why reading in between the lines was that she was just simply quite scared. So our on-call consultant called the oculoplastic team, and I was not party to the conversation, but I imagine that it went something like this: help. This is a known blind eye with chronic retinal detachment and rubeosis, and it looks like extruded ocular contents to me from an autoevisceration. So the oculoplastics team naturally said, sure, no problem. We'll do an emergency evisceration first thing tomorrow. So we decided to proceed with an evisceration the following day, and we put in a 16mm implant as the scleral shell was quite shrunken, almost like a physis bulbi. And the histology came back as a melanoma. So it was S100 positive. S100 is a marker for melanocytes as well as other tumors, and it was also positive for HBM45 and melanin A. Both are antibodies linked to melanin production and therefore melanocytes. It had an epithelioid cell type, which confers a worse prognosis. There was BAP1 inactivation, which is a poor prognostic feature and increases the metastatic risk. And with such a large mass, it makes it difficult to determine whether this was a conjunctival melanoma that traveled back or uveal melanoma that traveled forwards. So BRAF is part of a cytoplasmic signaling cascade that acts as a conduit between nuclear activity and growth factors, and it is more common in cutaneous and conjunctival melanomas. So the fact that it was negative means that it was more likely to be uveal. And there was also chromosome 8 duplication, which again is suggestive of a uveal origin and also confers a worse prognosis. So this is the histology here. You can see that almost all areas, it's almost virtually tumor, with the odd area of normal tissue. And this is in this area here. So if we zoom in, we can see, can you see my mouse here?
Yes.
Yes, so this is an area of normal epithelium all around here, and it comes to this area here. So if we zoom in once again, we can see that this long arrow here is pointing to the corneal stroma. This shorter arrow is pointing to this curvy pink layer, which is the Bowman's layer. And then this black arrow is pointing to the epithelium, which is then extending all the way around. And if we zoom in on this area, we can see that there are many areas of pigmentation, but also these dark prominent nuclei are all tumor cells, and highlighted is a mitotic body. And a high mitotic cell count is more indicative of a higher grade tumor. Now, as immunohistochemistry showed poor prognostic features, post-op imaging was done, and the MRI showed no scleral extension. Unfortunately, the ultrasound liver showed 2 lesions within the right lobe, and these were confirmed as metabolically active on the PET-CT scans. So currently, she has already been seen by one of our ocular oncology centers in Sheffield. They felt that no further surgical intervention was needed and a referral to a liver oncologist was made. And she has had her first visit with the artificial eye team and is due to be fitted with a prosthesis once lockdown eases. So thank you very much for the opportunity once again. The learning points from this case we felt were always see a patient preoperatively before deciding on management, even if the referral is from a senior colleague. Ideally, this patient would have, of course, had an enucleation rather than an evisceration. If a B scan is not possible, then consider CT or MRI orbits preoperatively and have a low threshold for systemic imaging for the staging of a tumor. In our experience, whole body PET CT is more sensitive for tumor staging than whole body CT only. Thank you once again.
Thank you. In the interest of time, I would like Priyanka Mandal to carry on with the next presentation, please.
Okay, that's fine. Thank you. Okay, can you see and hear me?
Yeah, clearly, no problem.
Oh, and can you see my screen? Yeah?
Yeah.
Super. Okay, so good morning and afternoon and evening. So thank you for having me. My name is Priyanka Mandal, and I'm going to present a case entitled The Visual Impact of Firework Injuries. So our case begins with a 29-year-old male who attended the emergency department. He had lost his vision following a fireworks injury, which he sustained at a home firework display. So the story goes that the patient lit a rocket, which was being held by his brother-in-law. However, once it was lit, instead of it going straight up into the sky, it went sideways and straight into the patient's face. So the patient was in significant pain and therefore very difficult to examine. He was noted by A&E to have multiple facial injuries and a right eye open globe injury. He was therefore referred to the ophthalmic team for further management. So examination showed that the visual acuity was reduced to no perception of light in the right eye and perception of light in the left eye. The right side of his face had a large lower lid laceration extending to the cheek with an extensive subconjunctival hemorrhage. The cornea was intact. He had a circumferential scleral laceration from 12 o'clock to 6 o'clock medially, and he also had a superficial laceration just below his left brow and left upper lid. As stated, his left eye vision was reduced to perception of light. Though the globe was intact, he had extensive corneal edema and a hyphema in the anterior chamber. As there was no fundal view, we performed a B scan, which did not show any evidence of retinal detachment or significant vitreous hemorrhage. He underwent a CT scan, and here's an axial view of that scan, which, as you can see, shows a collapsed right globe with a hyperdense orbital foreign body behind the lateral aspect of that collapsed globe. This is a coronal view of the CT scan, which, as you can see, shows multiple hyperdense foreign bodies within the right maxillary sinus. And then from there, it seems to extend into the right orbital intracoronal space through a fracture in the inferior orbital wall. There's no other intracoronal pathology noted on the scan. With these clinical and scan findings, a decision was made to take the patient to theatre for exploration of the wound, removal of the foreign body, along with repair of the scleral wound and lid lacerations. So the surgery is done jointly along with the maxillofacial surgeons. So here are some perioperative images. So here the facial wound and maxillary sinus was first explored and multiple foreign bodies were removed. Slightly closer up image. So it appears that this is the casing of the fireworks that's being taken out. Here's another image exposing the wound and the maxillary sinus. And here's several images showing several foreign bodies which were removed from the orbit and the maxillary sinus, and amongst them are some bony fragments. So after cleaning the wound, the scleral laceration and facial wounds were then sutured. And post-operatively, the patient received oral and topical antibiotics, topical steroids in both eyes, and cyclopedics to the right eye. So these images are from day 4 post-op, where the right eye showed an intact scleral wound and the facial wounds appeared to be healing. The patient was aware that his right eye vision would not improve. However, his vision in his left eye was still quite poor at count fingers. The left eye showed extensive corneal edema. His hyphema had reduced, and we could now see that an iridodialysis was there between 1 and 2 o'clock in the left eye. There was significant concern about the visual prognosis in his only eye. We felt that the corneal edema was probably due to the blast injury, which may have caused endothelial damage, but it was difficult to predict how much vision would recover. We increased his topical steroids to hourly in the left eye in hope that this would reduce the inflammation and the corneal edema. So 3 weeks post-operatively, his left eye vision has improved to 6/7.5 with resolution of the corneal edema and hyphema. Fundal examination of the left eye showed some peripheral vitreous hemorrhage supratemporally, but otherwise was unremarkable. So around 75% of firework-related ocular injuries occur in small family-type firework displays. A BOSU study on serious firework injuries in the UK showed that 26% of patients had a penetrating injury, 53% required ocular surgery, and a 6-month follow-up visual acuity was quite poor in the majority of cases at 660 or worse. So their conclusion is, of course, that it's a preventable cause of visual disability, particularly amongst young men. This study was quite a large study looking at 123 patients, of whom 37% had severe trauma. 7% of these patients had corneal edema following firework injuries. So this paper looked at 65 war veterans from Iraq and Afghanistan, and they described closed globe injuries following blast exposure. They found that there was endothelial cell abnormalities in 37% of patients and with reduced mean endothelial cell density. And they, even though it's a closed eye injury, they assume that it's the transfer of forces to the endothelium through the closed eye, which is causing cell loss. So the main learning points here is that firework injury is a preventable cause of blindness in young males, with home firework displays carrying a higher risk. Patients can have closed globe injuries with extensive corneal edema, which can resolve with good prognosis. Here, the multidisciplinary team approach was the most important, and that's everything. So thank you very much for listening. If you have any questions, please let me know in the comments. Thanks.
Thank you, Aman and Priyanka. In view of time, I'm just going to touch only one aspect because it's going around rampantly in the chat forum, which is for Aman in particular, the pre-op investigation. Why was the patient not subjected to ultrasound or scans before you took up the evisceration procedure?
Yeah, so yes, I've seen the comments. Indeed, one should consider a preoperative CT or MRI orbits if the B scan is not possible. As to why it was not done, this comes to one of the other learning points that I mentioned, that it's always worth, as the oculoplastic surgeon, to review the patient preoperatively first. This was a referral that was made by one of our local consultant, and I think that there was a degree of taking the on-call consultant for his word that it looked like extruded ocular contents. And
the only comment I would make is that this was almost an admission of guilt, to be honest. Going back to basics, we should have pre-op imaged this patient without doubt, and intraoperatively, fortunately it all shelled out and the PET was negative in the orbit. Long term, who knows, and she had liver mets, but this is basically a learning point that no matter how experienced you are, it's back to basics. That we should have, I don't think a B scan would have been possible with the type of mass she had, but probably a CT or an MRI would have been more sensible.
Just one additional point, if I might, yes. And that is that you slipped in your history there that she'd had rubeosis and a chronic retinal detachment. That combination, clinical combination, you think melanoma until proven otherwise. It's worth crossing your mind. And that burst globe appearance is actually quite typical of advanced melanoma. I had one lady who came and she had it so long that it had curved the anterior surface to the back of her glasses to a -6 back curvature. Unbelievable.
There's one another floating in the forum, which I'm going to leave it for the end discussion, which is to do with law and fireworks. I think that'll take much longer time. So moving on to next one, Tristan, please.
Thanks very much, Coventry. We're going right down to London, where our next BOPS president has got his presentation ready. David, are you ready? David or one of his team?
His colleague is present.
Yeah.
Okay.
Moving on to Kavi. Thank you. Kavi's got a super case.
Okay, hello, everyone. So I'm going to present a case of synoorbital disease, which was referred to me recently. So this is a case of a 21-year-old female who had 3 weeks history of reduced vision in her right eye and headaches. She
Hi,
also
can you screen share? You're not on screen share.
Oh, sorry. Let me just screen share. Is it visible now?
Not yet, Kavi.
Down the bottom. The green button at the bottom.
This, but how about now?
On the bottom of your screen.
There's a green button on the bottom row.
Yes, I've
Share screen.
Check before the meeting. It was working. So
it was working because I apologize for this. How about now?
Yeah.
Okay, lovely. Great. So this is a 21-year-old female who was referred with 3 weeks history of reduced vision in her right eye associated with headaches. And she also described 3 episodes of her globe coming out of the socket, which she had to push it back with her fingers. So on further questioning, she had 6 months history of gradual prominence of her right eye. This is her clinical appearance at presentation. And she had reduced visual function, vision in the right eye 636 with reduced color plates, evident relative afferent pupillar defect with 6 millimeters of relative proptosis and inferolateral globe displacement. So here you can see the imaging where a large, well-circumscribed lesion was seen involving the ethmoid sinus, as well as the roof of the orbit, medial wall, skull base, and causing some compression of the optic nerve at the apex. On the sagittal view, you can see the extension of it into the anterior cranial fossa and a bit into the middle cranial fossa. So if you look on the bony views, you may also notice some slight ground glass appearance in some parts of the periphery of the lesion. The MR imaging showed an iso-intense lesion on T1 weighted and hyperintense on T2 with distortion of the frontal lobe and some midline shift. And post-contrast imaging showed septations within the lesion with some enhancement. So at this stage, her symptoms were getting worse, headache and vision was declining. So we decided to proceed with a debulk and procedure and decompression via a combined approach with endoscopic, endonasal and retrocaruncular approach, which was done with my ENT colleague. So this is the endoscopic view of the lesion. You can see the inferior aspect of it bulging, as well as lateralization of the medial wall of the orbit. As we enter through the lesion, we could see the anterior ethmoidal artery bypassing through the cavity. And you can see this cementoid kind of abnormal, partially calcified bony tissue in the periphery of the lesion. So she was doing fine on day 1 post-op. Vision improved to 615 and she regained most of her color vision. However, 3 days post-operatively, the patient complains of severe headache, feeling nausea, photophobia, and having rhinorrhea as well. So we got her in the hospital and repeated the CT scan, which showed a lot of air in the extradural space. This was thought to be a presumed defect in the skull base, although it wasn't evident on imaging. So she had essentially pneumocephalus. This was managed successfully with the conservative approach, and 5 days later, everything settled. She became asymptomatic, and the imaging findings also disappeared. So fortunately, she did not progress to this type of picture, which is tension pneumocephalus, and is classically described as a Mount Fuji sign based on its radiological finding. I just received the histopathology report a few days ago, and this does not belong to this patient, but it showed a benign fibro-osseous lesion with immature, non-calcified cemented osteoid rim and some intervening fibrous stroma, which was suggestive of ossifying fibroma. So there are three main benign fibro-osseous lesions affecting the paranasal sinuses, and these share similarities in terms of replacement of the normal bone with the fibrocellular stroma that contains various amount of foci of mineralization and ossification. The commonest one is osteoma, which is well-defined, slowly growing lesion that is very highly calcified and mineralized. The second most common one is fibrous dysplasia, which is usually shows hypertrophy and deformity of the bone with ground glass appearance, which is classical. And the least common one is the ossified fibroma that manifests more like a tumor with a calcified periphery and fibrous stroma with various degrees of calcification inside of it. So ossified fibroma is relatively rare and mainly involves the maxilla or mandible and occasionally can affect the long bones. Sinus involvement is pretty uncommon and typically affects the ethmoid sinus. Patients may be asymptomatic or present with facial pain, swelling, and deformity. And if it's orbiting involved, they could have proptosis. It usually affects people in their 20s and 30s also, although there's also pediatric variant, the juvenile ossified fibroma, which is more invasive and has higher recurrence rate. Generally in the literature, the complete excision of the lesion is advised to avoid further recurrences. However, due to its anatomical location and intimate relation with the skull base, this is very difficult. So I think the main learning point is that although these osseous lesions are benign in nature, they can cause significant morbidity due to their anatomical location. And they have to be treated through a multidisciplinary management with a skull-based surgeon, ENT, and possibly neurosurgeon. One thing which would probably be very helpful is intraoperative image guidance. In these cases, as we saw, we had postoperative CSF leak and pneumocephalus, although we couldn't see anything, but it was very difficult exploration due to severe distortion of the anatomy intraoperatively. So thank you very much.
Thank you very much, Kaveh. Can I ask you, the history is fairly short, 6 months. Is this typical of these lesions?
No, they are typically slowly growing. This patient was only aware of 6 months. So I presume this has been going for much longer. Although in the literature, there are cases that have shown very rapid progression. But typically in younger cases, in the juvenile forms.
Yeah, I mean, it's a very silent area. You can absolutely have massive lesions in the ethmoids with relatively little signs and symptoms. The other thing is people are very unaware of lateral displacement of the globe. You can actually see it in her. Her globe was displaced maybe 6-8 millimeters laterally, but people are very insensitive to that as a change in the face, whereas vertical displacement and so on, people are much more aware of. So it remains silent, often, Tris, for a long time.
Thank you.
Right, moving on, we are now traveling up north to Manchester, where we have Teresa Lupion going to speak to us on a severe oculocardiac reflex. Teresa?
Thank you very much. So I'm going to share. Am I audible?
Yes, you are.
Okay, and can you see slideshow now?
Yeah.
Okay, fantastic. Thank you. So good morning, everyone. First of all, thank you for the invitation. My name is Teresa Lupion, and I'm going to present a case from Manchester Royal Eye Hospital. This is a 28-year-old woman who had a bilateral retinoblastoma in her childhood, treated with chemotherapy, retinucleation, and radiotherapy. She had a secondary hydroxyapatite implant, which was extruded, and therefore we replaced it with a dermis fat graft. Afterwards, she had 2 Coleman fat injections, and she developed, along the years, a contracted volume deficient right socket with a very hollow upper lid sulcus. To improve her appearance, we decided to inject 1 ml of Restylane in the right upper lid sulcus in 2018 with a very satisfactory outcome. However, she was seeking further improvement in her right volume socket deficiency, so we decided to operate on her 3 months ago. Before the procedure, she had her blood pressure and heart rate readings were absolutely unremarkable, so we proceeded under local anesthesia and sedation with fentanyl and midazolam. We injected into the orbit 1 ml of lignospan inferior temporally and another ml of voluma juvéderm in the inferior posterolateral aspect of the orbit using a 25 gauge blunt cannula. Immediately after the procedure, her blood pressure had gone up a little bit. But however, according to the post-op nurse review, at the time of the discharge, there was only a mild discomfort with a slightly lower blood pressure that was not fully documented in the chart. She was offered water and therefore discharged. 3 hours later, she rang us in pain, so we decided to bring her back to the hospital, where she presented with nausea, vomiting, and severe pain. At that time, her blood pressure and heart rate had gone down, but not significantly, so we proceeded with an orbital block of 5 mL of lidocaine plus bupivacaine. There was an immediate relief of pain, so at that moment, our working diagnosis was pain due to volume expansion in a very contracted socket. She was offered reversal of the filler, but she preferred to keep the effect as she was getting married 2 months later. So we admitted her on IV anti-emesis and analgesia, but at 10 p.m. that night, the pain recurred. We rediscussed the option of reversing the filler, but she declined again. So next morning, my consultant, Mr. Sachatola, happened to be talking with his friend, Mr. Rama Malhotra, and he suggested the idea of the possibility of an oculocardiac reflex. He advised to have an MRI scan done and to start her on IV mannitol to reduce the intraorbital pressure, which we did. So looking back retrospectively at that point, blood pressure and heart rate after the surgery had gone down, not significantly, but definitely gone down. So our new working diagnosis at that moment was an oculocardiac reflex. I'm showing here the MRI scan, and you can see the right upper lid sulcus filler, but most importantly, you can see that the right intraorbital filler was correctly placed, both intraconally and a component in the extraconal part, but without any migration in the intracranial compartment. So oculocardiac reflex can be defined as a drop of normally more or less 20% of the heart rate after either glove pressure or extraocular muscle traction. Some of the contributing risk factors can be ocular pain, ocular manipulation, or an increase in the intraorbital pressure. Additional to the decrease in the heart rate and blood pressure, there can be a vagal response with nausea and vomiting, dysrhythmia, and cardiac arrest. The most efficient treatment for this would be cessation immediately of this triggering stimulus or block of the ciliary ganglion, as it is part of the afferent pathway in this oculocardiac reflex. Fast-acting opioids, such as fentanyl, can precipitate the bradycardia in this situation. So to summarize, we just wanted to raise awareness of the importance and possibility of having an oculocardiac reflex when filling the orbit for volume expansion. This can potentially lead to serious complications and even has a risk of death. So our advice would be to cardiac monitor every patient that is going to have a filler of hyaluronic acid into the orbit and keep patients in at least until the anesthesia completely wears off. We should try and avoid or reduce the use of fast-acting opioids, but if we have any clinical features suggestive of oculocardiac reflex, we should monitor for dysrhythmias and consider urgent removal of the stimulus. Thank you very much.
Thanks for keeping it to time, Teresa. Extremely interesting case, but quite rightly, I think Tristan McMillan asked about differential diagnosis. Could it have been due to any other thing, like you discussed about fentanyl?
Well, as I said, at first, the only option that we were managing in our heads was the pain in the socket causing all this vagal response. So it could have been a vasovagal syncope at first time. But as I said, looking back retrospectively, the blood pressure had gone down, which is normal, but additionally, the heart rate had gone down and sustained in time for a few hours. So that was not compatible with a vasovagal syncope anymore. And actually, we think that the triggering stimulus was both, first, the pain, second, the increase in the volume inside the socket, in a very contracted socket after radiation, that was stretching, as you can see in the MRI, the inferior rectus and the lateral rectus, because there was an intraconal and extraconal component. So it was everything engaging and stretching the muscles, and we think that triggered. But our main differential could have been vasovagal syncope. But finally, the whole picture was more pointing towards oculocardiac reflex.
Yeah, just to add, we had one patient whom we published as a case report many years ago. Joyce was involved. A patient developed similar symptoms post-op following a secondary implant in the orbit. So we never used to give routine long-acting anesthetic before. Nowadays, in case we do any secondary orbital implant, which is extremely rare, we tend to inject long-acting local anesthetic into the orbit after general anesthetic, just to tide over this particular situation.
Can I add a case against myself, very similar to Ron? I had a chap with a very tight orbit. We did a ball implant, really pulled on the muscles, and he woke up from the anesthesia cold, sweaty, and we thought he'd had an infarct. I mean, really cold and sweaty, just like an acute MI. And his blood pressure was low, but his pulse was struggling along at sort of 70 odd. It turned out we were caught out. He was actually extremely vasovagal. And what he had was an implanted pacemaker, which is why his pulse rate was still going along at 70 odd. We were completely caught out. So he hadn't had an infarct, thank goodness. But you can be caught out and they can feel absolutely dreadful. We don't, Ron, tend to give long-acting local because it tends to wear off rather late in the night, like 10 o'clock, 11 o'clock, 12 o'clock at night. And you're the one who gets the call, or the GP. And I had a really angry GP really give us real hassle after we did that for a while. So we've given up on that.
Right.
Actually, that was our case. We injected bupivacaine and a few hours later it wore off. And it was 10 p.m. actually. So
yeah, no, that's right. It's very antisocial.
Thank you very much.
Thank you.
Thank you very much for that interesting discussion. Over to Tristan to go to Northampton now.
Yes, indeed. My twin from Northampton, Tristan McMullen, will take over, or at least his registrar, Sagan. Thank you.
Good morning. Can you hear me?
Yes.
Yes.
Good morning to everyone. Thank you for the invitation to speak. I'll be talking about the stage square procedure for lentigo maligna.
Can you share the screen, please?
I shall.
That's excellent.
Okay, I'll be talking about the stage square procedure used in managing lentigo maligna. We had a 68-year-old lady present in January 2016. She noted a right lower lid and lateral canthal area of pigmentation. This was adjacent to a site of previous reconstructive surgery. Going back into the past, 5 years previously, she had a lentigo maligna excised from a right upper cheek with 2 millimeter margins attained. She was subsequently discharged from follow-up. In terms of her past medical history, she had previous breast cancer and a left cheek BCC excision. She was referred to the local maxillofacial team, and further excision was discussed after being discussed at the MDT. The wider excision was advised to include the lateral upper and lower lid. In June 2017, she was referred to oculoplastics and mapping biopsies were performed. And indeed, lentigo maligna affecting the inferior eyelid and lateral canthus was confirmed. She was referred to the Mohs service and underwent a staged square procedure, aka a Johnson square. In January 2018, she had a cervicofacial rotation flap in conjunction with the maxillofacial team. And on review in May 2018, a degree of lateral lagophthalmos was noted. She subsequently underwent a skin graft reconstruction and things settled down quite satisfactorily. At her last follow-up in March 2020, she had no concerns and there were no new areas of pigmentation. The image on the right shows a post-operative picture of the lady in question. So lentigo maligna is a melanocytic neoplasm which occurs on sun-exposed skin. It is thought to be caused by intermittent bursts of sun damage to the skin as opposed to a cumulative dose of sun damage. It was first described by Hutchinson in 1890 and called a senile freckle with progressive radial growth. It's thought to be an in situ phase of lentigo maligna melanoma, and classically lesions are typically ill-defined and widespread, which makes surgical excision difficult in the periorbital area. Typically, patients have this condition ages 70 to 80. They could be a new asymptomatic pigmented macule or change in the size, shape and color of a long-standing freckle. It can start as a tan brown macule, but we have a variegated pigmentation and show black or melanotic features. It usually is slow growing but can progress in a prolonged radial growth pattern before becoming a more vertical, aggressive growth phase. So this slide shows H&E stain of a lid affected with lentigo maligna. It shows nests of melanocytes at the epidermal junction, and you can see cells with enlarged hyperchromatic nuclei. So the treatment of this condition, the gold standard would be surgical excision. In the literature, you have frozen sections using the Mohs micrographic surgery and stage excision with the paraffin embedded permanent sections. In patients that are poor surgical candidates, topical imiquimod and radiotherapy have been described, although their efficacy have not been demonstrated. Recurrence in lentigo maligna is related to the fact that atypical melanocytes have subclinical extension beyond the clinical margins, which may only be detected on a microscopic level. Therefore, recurrence rates can vary with the excision method used. The risk and rate of progression of lentigo maligna to lentigo maligna melanoma is unclear. And in some cases, it can be seen to progress to invasive melanoma in about 30 to 50% of cases. So Mohs surgery, as we know, is a tissue sparing technique. However, its role in the context of lentigo maligna is very controversial. There's been a large discrepancy in curative rates described in the literature, and the inaccuracy of processing the frozen sections is due to an altered morphology of the keratinocytes, which can mimic altered melanocytes, and also cytoplasmic features of such as retraction of lentigo maligna are lost. Therefore, frozen section is not an accurate way of removing this lentigo maligna in a periorbital area. So I'm going to describe what the Johnson square technique is. It's a staged technique used for removing ill-defined lesions that have a high recurrence rate due to subclinical spread, e.g. lentigo maligna. It utilizes paraffin wax embedded peripheral vertical sections for margin control. It ensures complete clearance as the surgical margins are usually examined at distances of 2 to 5 millimeters from the periphery of the lesion. So this slide shows how the square technique is performed. The clinical margins around the lesion are first of all drawn, and then a margin of less than 5 millimeters are drawn around in a square shape with square edges. An additional square of 2 to 3 millimeters around this initial square is then drawn, and then strips are excised to the level of the underlying adipose tissue. The edges are subsequently inked with colored dye for orientation. Samples from the peripheral area are then fixed in formalin and sent for analysis, and then phase permanent section analysis is performed. The excised strips leave a thin defect around the central core, but interestingly, the lentigo melanoma maligna remains in position on the skin and isn't excised. The patient returns within a week, and if the positive margins are present, further strips can be taken. If the margins are clear, then definitive excision of the central lentigo maligna can be done with reconstruction. It's at the discretion of the clinician to either suture the defect or just to allow it to granulate. The subsequent slide shows a patient who had a temporary closure performed on the left, and on the right, this was left to granulate, and it was found that the lateral margin was involved, so subsequently further specimens were sent off. So in summary, a lentigo maligna may progress to lentigo maligna melanoma. Surgical excision of lentigo maligna is difficult with the risk of recurrence. Achieving clear margins may require extensive tissue loss and make reconstruction quite challenging. and therefore the stage square procedure allows clear margins to be achieved whilst conserving a tissue. Thank you very much.
Thank you very much, Sagan. Are there any questions from the audience, comments? Can I just ask, in your department, do you tend to do your Mohs excision yourself, or do you farm it out to the dermatologists?
We farm it out to the dermatologists.
So
sorry.
So yeah, we send some patients for Mohs, not many to be honest. But this was just really to highlight the technique of the Johnson square, which the Nottingham group have described. And it's similar to the calamari ring, which I guess is the Australian or Antipodean equivalent. But it's just a way of, I mean, I think one point that probably should be just brought out is that central area then gets sacrificed at the end, and then you do your reconstruction. But it's a sort of very, very slow Mohs. It's like a rolling barrage until you've cleared everything, and then you can go back in and do your reconstruction at your leisure. But this patient had had 2 previous excisions, and so I felt that just to sort of pretend I was going to be able to get it all was just not an option. So we did quite a big thing for her, but touch wood, she's been all right since.
Thank you for these wise words from Northampton. I'll hand over to the next chair.
Thank you.
Hi, can I invite Usha Kim from Arvind Eye Hospital Systems, who I think in the world do the maximum lid lacrimal and orbit pathology, both clinically and surgically. And Bipasha Mukherjee, who's again an oculoplastic orbit surgeon in Shankar Nethralaya, Chennai, which again is one of the largest eye hospitals in India, if not the world. Welcome both of you to chair the next session. Thank you.
Dr. Usha, are you there? Okay, greetings from India, namaste. I cannot get any response from Dr. Usha, so shall we carry on?
Here, Dr. Bipasha.
Yeah.
Thanks to
hi.
Yeah. So thanks to Dr. Sampath for putting this very interesting session. All the presentations were succinct and very, very interesting. Thanks to you, Dr. Sampath, and bringing the whole world together, I think, despite the COVID. And also, COVID has been to our advantage at this point of time. So without wasting much of our time, I think we'll move on to the presentations. Dr. Bipasha, can you introduce the first speaker?
Sure. The first speaker is from Shankara Devanesthala, which is situated in Guwahati, the northeast of India. And Dr. Shyam Sundar Mahapatra will be presenting a case, very interesting case of socket reconstruction. And he belongs to the team of the beautiful Dr. Kasturi Bhattacharya.
Thank you, ma'am.
Dr. Shyam.
So good afternoon and good evening to all. I am sharing my screen. Is it visible?
Yeah, nice and clear. Thank you.
And am I audible, sir?
Yes. Yes.
This is fantastic. Thank you. So today I am going to present a case of multi-layered reconstruction in a severely contracted socket. I have no financial interest here to disclose. So this is a 28 years old gentleman came to us for consultation regarding his right anophthalmic socket. He has a history of enucleation, which was done at the age of 3 years, followed by a course of radiotherapy. So he was, for the initial few years, he was able to use the prosthesis, but later when the socket contracture was started, he was not able to use the prosthesis. So he has taken opinion from different parts of the country, and he was undergone mucous membrane grafting once elsewhere, and dermis fat graft was performed twice elsewhere. But suddenly, neither of these was successful. So we have examined the case and we have come to a diagnosis of grade 5 contracted socket as per the Gopal Krishnan classification. But we have wanted to see the bony orbit, and we have advised a CT scan of orbit with 3D reconstruction. Here in the 3D reconstruction of CT orbit, we can compare the both side of the orbits, and you can see here the difference between the right and left socket. So in comparison with the bony socket, you can see it's so much of contraction is there in comparison with the left socket in all the dimension, including horizontal, vertical, as well as anterior, posterior. To do a further and well measurement of the socket, we have done a 3D printing of this 3D reconstruction, and we can see the measurements here. You can see there is so much of reduction in the horizontal dimension of the right socket in comparison with the left one, and also you can see the anterior posterior shortening. So in this patient, the grade 5 contractile socket has all its components: bony contracture, soft tissue contracture, and mucous membrane contracture. So the question comes to us, how to address all the three components of the contracted socket. This may be a normal like other cases, but the condition was a bit different for this patient. This patient has already undergone multiple surgeries. He has traveled to ask for opinion from a different part of the country. He has in under psychologist consultation, and he is in under psychological stress just because he could not afford a prosthesis that can be fitted into his right socket. And he was very keen to do a last surgery because he has already undergone many surgeries, many consultation, and he was absolutely left no hope for the given a prosthesis and a good looking cosmetic appearance in the right side. So he requested us, just kindly do only a single procedure so that I can afford a prosthesis, we can be fitted, and I can look good in the right eye also. So we have planned for a multi-layered reconstruction of this socket. So for the bony contracture, we have planned a orbital rim and malar advancement. For the soft tissue part, we have planned for a temporalis muscle flap. And for the mucous membrane part, we have planned for a amniotic membrane graft. Along with fornix forming suture and conformal placement was planned as a single surgery. So I will go through the surgical procedure. So you can see this is the 28-year-old gentleman with a severely contracted socket in having all the three components: bony, soft tissue, and mucous membrane. You can see how much the difference is there, as already you have seen in the 3D reconstruction CT orbits, and also in the 3D reconstruction which have made the 3D printout, and we can really take the measurements and we can see how much the contraction is there in terms of the bony contracture also. So you can see in this 3D printout, which has already been shown, you can see the difference in right and left side in all dimensions. Now we have taken the patient for surgery. We have done a lateral canthotomy and lateral cantholysis. We have dissected the conjunctiva. We have done a lid split in the middle part of lower eyelid. We dissected the orbicularis and soft tissue, and we have removed the periosteum, exposed the inferolateral orbital rim. Now we have used a piezoelectric cutter to separate this orbital rim of bone. Here we have used piezoelectric just to save the underlying soft tissue because it only cuts the bone. And here it is important because if we completely remove this part of the bone, then there might be a chance of bony necrosis. So here we use the Stryker's saw to separate this bony end block from the orbital rim. And here you can see the infraorbital nerve and vascular complex is very well preserved with this bony block. Now we have put on the incision over the temporal fascia, and we have separated this temporalis muscle, the superficial part only, because preservation of the deeper part is important. Otherwise, there will be so much of following of the temporal fascia. So here we have separated this one using a Alice tissue forceps. We pulled the superficial temporalis muscle flap into the orbit, and we have sutured it both well inferiorly and superiorly with the remnants of conjunctiva. And we have well placed this temporalis muscle flap into the socket. And we have secured it with suture, and you can see it's very well placed temporalis muscle graft. And so what we have done actually in this patient, so you can see in this animation, you can see this is the orbital malar rim which we have actually separated, and we have rotated it anterior superiorly. but we have not disturbed the both side posterior part. Otherwise, there will be chance of bony necrosis. And rotating it anterior superiorly, we have put it in the position with plates and screws. Now we have sutured all the incisions and secured it properly with sutures. And here you have seen the sutures was done, and this is the mucous membrane which was put above the temporalis muscle flap, and it's positioned properly. And we have put a conformer and placed the fornix forming sutures. Now this is the final appearance just immediate after the surgery. Coming to the immediate postoperative follow-up, this is on the very next day to the surgery. You can see there is so much of volume gain in comparison with the preoperative, and you can also compare with the right and left side in the very first postoperative day only. So when the patient comes for 3 months follow-up, you can see the process is very well placed, but the patient has some amount of apprehension here because the patient has developed some amount of superior sulcus deformity. You can see here, this is the superior sulcus deformity, and patient really want if you can do something with so that he looks much better than this appearance. So for the superior sulcus deformity, we have planned a orbital filler injection. So this is the way we have put a orbital superior filler injection. I will take to a very short video how we have given the filler. So in the superior part of the orbit, first we have placed the filler into a deeper part of the orbital tissue, and second one we have given it more anterior position in the subperiosteal region. And following the filler injection, we have put the prosthesis, and you can see immediately you can see how much the volume we have replaced. So this is the patient when came after 1 year of follow-up. You can see so much of improvement in terms of the cosmetic appearance. The prosthesis is in very well position. You can see when we have seen the first time patient, there was so much of deficit in volume. So now you can see there is hardly a difference between the right and left eye, and patient is very happy with this amount of cosmetic reconstruction. So here you can see when the patient came with the first time, you see how much the socket was contracted. There was no volume at all. We cannot afford giving a prosthesis in this right anophthalmic socket. And here the patient comes after 1 year of follow-up. You can see how good the patient is looking. Patient is highly satisfied. His psychological stress is also a bit improved with this one. And even the patient is still with communication with us, and the patient is very happy with his cosmetic correction. So this is the consent of the patient. Thank you to my mentor, Dr. Kasturi Bhattacharya ma'am. Thank you.
Great case. Yes, thank you. I think that was an excellent case. The only doubt we have was you used the amniotic membrane, right? Instead of the...
Yes, ma'am. Yes,
yeah.
Yes, it is amniotic membrane. I think he mentioned it as a mucous membrane, but
yeah,
it was basically amniotic membrane.
Yeah, okay. The question is whether...
Yeah, which filler did you use? I have replied it in the chat. It is a Juvidum voluma because that gives a maximum amount of volume. Basically, we all know the different fillers. Some gives a lift, some gives a volume, but some gives also a filling effect. But in this patient, basically, we wanted a volume. He had a superior sulcus deformity, so we have decided to go for the voluma.
Excellent results, Kasturi. I think that was very good. Yeah, Dr. Bipasha has a question. Bipasha?
Yeah, Dr. Senthil is asking why not mucous membrane graft? Yeah, mucous membrane, because when we had checked, he had all the 3-layer deficiency. But if you look to the interior, like this was not a very dry type of mucosal contracture. It was basically a wet type. So we did not feel that at that time because we wanted to keep it as a last option, because when he went to tertiary eye care center elsewhere, so the first surgery that was done for him was a mucous membrane. So he already has a mucous membrane. And then somewhere else he had twice or thrice dermis fat graft. So considering that he already has a mucosa, which was taken from his lower lip, so this time we decided that why don't we try with the amniotic membrane, because we all know that amniotic membrane has a good anti-inflammatory, antibiotic effect also.
All right, thank you. Yeah, I think we'll move on to the next presentation. Thank you, Kasturi and team. That was an excellent presentation.
Thank you.
Thank you, ma'am.
So now we'll move on to the next presentation from Dr. Mritika Sen, representing Center for Sight, a mystery case.
So, good morning, good afternoon, good evening. Thank you for this wonderful opportunity. I'll just share my screen. Yeah, is it visible?
Not yet.
I'll just do that.
It says it's coming.
Yeah. Yeah, it's visible.
It's fine. Good. Thank you.
So let us now venture into the unknown. A 25-year-old healthy male presented with a 4-day history of swelling in the upper lid of the left eye. His vision was 6/6, his ocular movements were full, and his Schirmer's was normal in both eyes. If we take a closer look, there was definite fullness near the lateral canthal area. He had a proptosis of 3 millimeter, and in down gaze, there was a definite mass in the superotemporal quadrant of the left orbit. On elevating the eyelid, there was a yellowish pink, firm, relatively immobile subconjunctival mass. The posterior border was not palpable, and it was not reducible, non-tender, non-pulsatile. On elevating the eyelid further, there were dilated tortuous conjunctival vessels. The palpebral lobe of the conjunctiva seemed normal, so we advised a CT scan. On CT scan, there was a well-circumscribed homogeneous lesion involving the lateral rectus. It was in the epibulbar plane and just anterior to and involving the insertion of lateral rectus. There was a tongue-shaped extension going into the retrobulbar space quite close to the optic nerve. So what do you think were the differentials and how would you like to proceed in this case? Okay, so well, we considered based on the clinical presentation, a subconjunctival fat prolapse or a dermolipoma, and along with the radiological findings, we added a lymphoproliferative or a histiocytic lesion to our list of differentials, and we proceeded with a biopsy. In order to protect the vital structures, we performed a debulking surgery by the transconjunctival route. On histopathology, it was a predominantly hypocellular lesion with areas of hypercellularity in a rich myxoid stroma. There were areas of hyalinized collagen. On a higher magnification, there was ropey collagen and spindle-shaped cells with fusiform nuclei. Our differentials at this stage were a low-grade fibromyxoid sarcoma, a myxoid solitary fibrous tumor, myxoma, and a rhabdomyosarcoma. So we proceeded with immunohistochemistry. On immunohistochemistry, the lesion was strongly and diffusely positive for CD34, BCL2, and CD99 as well as Vimentin. The Chi-67 index was less than 3%. So our diagnosis was a myxoid solitary fibrous tumor. Solitary fibrous tumor is a relatively gray area considering the descriptions used for it, a tumor of unknown origin occurring at all sites and in all age groups. Even the typical histopathology is described as patternless pattern. So let's see if we can elaborate on this vague entity a little bit more. Well, it was first described by Vestra, who described 2 cases of orbital SFTs along with the specific immunohistochemical features. Orbital SFTs comprise 6% of all cases with a median age of 34 years. Typically, it presents as a unilateral painless proptosis, fullness or ptosis, and it has an indolent benign course. Imaging is not very specific, but it shows mild to moderate enhancement, and it is iso-intense to gray matter on T1. On histopathology, it is a pseudo-encapsulated lesion, predominantly hypercellular with spindle or stellate-shaped cells and ropey collagen, just like in our case. It has hemangioparasitoma-like staghorn pattern of vessels, And it is now considered to be a spectrum which includes fibrous histiocytoma, hemangiopericytoma, giant cell angiosarcoma. There are certain features which indicate a more aggressive behavior or a malignant transformation, such as areas of pleomorphism, necrosis, mitosis, more than 4 per 10 high power fields. Ours was the myxoid variant, but there are other variants also. Immunohistochemistry is necessary for the diagnosis, and solitary fibrous tumor is positive for CD34, BCL2, CD99. More recently, TFE-E3 and STAT6 are considered, have been found out to be much more specific for it. On histopathology, myxoid solitary fibrous tumor should be differentiated from a low-grade fibromyxoid sarcoma, myxoid neurofibroma, the botroid variant of rhabdomyosarcoma, and a myxoma, and a fat-free spindle cell sarcoma. And this is possible with immunohistochemical features. So orbital SFT has a benign course. However, recurrent cases show local invasion. In the orbit, recurrence is seen in 19 to 25% of the cases, with incomplete excision being the most important risk factor. Now, malignant transformation or primary malignant soft tissue solitary fibrous tumor, 5 or 6 cases have been described in literature. However, distant metastasis and death with an orbital SFT has not been reported. These figures are for SFTs at other anatomical sites. Coming to the management, the treatment of choice is complete excision. For residual, recurrent, locally infiltrative and metastatic lesions, there are options. These tumors, they are not very chemosensitive to conventional regimen using doxorubicin, paclitaxel or gemcitabine. However, novel targeted therapy have shown encouraging results. Radiotherapy can be used either as a neoadjuvant or an adjuvant option. For orbital SFTs, neoadjuvant radiotherapy has not been used, but adjuvant radiotherapy in the form of IMRT, stereotactic or gamma knife stereosurgery has shown excellent local control. So even in our patient, we advise an adjuvant radiotherapy. However, the patient decided to observe it. He returned after 5 months with a recurrence. So we decided to continue. So a repeat MRI was done and it showed an increase in the retrobulbar component. It was abutting the optic nerve and infiltrating the lateral rectus muscle. So we decided to go ahead with a second debulking surgery. And in order to protect the vital structures, we performed this debulking surgery. The lacrimal gland was protected with the help of a Demers. And we found that this lesion was going underneath the lateral rectus muscle. We carefully hooked the lateral rectus muscle and cautiously separated the tumor from it. We proceeded with the dissection in the subtenon's plane, and we found a plane between the superficial and the deeper component of this tumor. The superficial part would be excised later. As we proceeded with the dissection further, the tumor kept on becoming broader posteriorly. We measured the distance that we had dissected from the limbus, and we found that we were approaching the optic nerve. So we decided to stop further dissection, and we excised with the help of a cryoprobe. During excision, we found that it was becoming continuous with the normal intraconal fat. The superficial component is being excised here, and the conjunctiva was simply glued back on. On histopathology, the features were the same, and it was a case of recurrent solitary fibrous tumor. So adjuvant radiotherapy was given a total dose of 66 gray in 33 fractions. 3 months post radiotherapy, the patient is doing well. His vision is 6/6 and his Schirmer's is also good. He has no complication of radiation. This is the 4th case of a subconjunctival presentation of solitary fibrous tumor. Here, I would just like to highlight the varied presentation. In the first case, the differential diagnosis was a choroidal melanoma with extraocular extension. In the second case, the differentials were conjunctival stromal tumors. And in our case, the patient presented as a case of dermolipoma, a subconjunctival fat prolapse, or a lymphoproliferative and a histiocytic lesion. So an SFT should be considered in the differential of all these. While complete excision is the treatment of choice, however, adjuvant radiotherapy provides encouraging results and has shown very good local tumor control in cases where this is not possible. Diagnosis is, of course, dependent on immunohistochemistry, and long-term follow-up is essential. Thank you.
I think that was a very good management strategy. But I'd like to ask Dr. Rose about how he would have managed his case if he had to deal with a similar scenario.
Yes, I mean, it's a difficult one because until you know the histology, you cannot be certain what you're dealing with. But I didn't think it was dermolipoma in the sense that there was no abnormal conjunctiva, in other words, no dermal or epidermal component to it. And it also doesn't quite have the look. And I've never seen a dermolipoma going back behind the globe, actually wrapping around the globe towards the optic nerve. But, you know, other lesions, as you mentioned, could present that way. I would have probably liked it or gone for intact excision is first surgery whilst you're there, but still with some uncertainty about the diagnosis. I mean, I've been caught out with SFTs over the years. They can recur extremely late and locally. So even with intact excision, I've had them recur 6-7 years afterwards. And I wasn't expecting it. We were all thinking, crumbs, that's doing well. And then the chap presents with recurrence on his skull base. And so we were caught out with that one. So they are a difficult group to deal with. Radiotherapy, he's had 60 gray, and a lot of that will scatter into his optic nerve. So although he's all right at 3 months, I just wonder what his acuity will be like at 3 years when he may have developed optic neuropathy, post-radiation optic neuropathy.
Thank you.
Steph, I've had a patient similar where it turned aggressively malignant about 10 years later. The problem was that was his only seeing eye with a large SFT. So I couldn't obviously aggressively manage him, but he's had 3 or 4 debulks.
Yeah, certainly I've done repeated debulks in patients referred with recurrent disease. But no, it's always the only remaining eye that has the tumor, Ron. That's just life.
Thank you, Dr. Rose. Vipasha, can I request you to call the next speaker?
Yeah, the next presenter is Dr. Rituja from Nara Netrala, Bangalore, and she will be presenting a case of sebaceous gland carcinoma.
Good evening, everyone, and thank you for this wonderful opportunity. So a middle-aged gentleman had come to us with the complaints of dry eye since 3 years. But the thing was that he was symptomatic only in his left eye. So here what we can see compared to the right eye is that the left eye has a slightly distorted margin with a bit of thickening and some congestion. So we were wondering what we were missing. So when we everted the lid after doing a fluorescein stain, etc., to see the corneal status, we found that there was definite thickening of the margin with distortion of the meibomian gland orifices. The sharp junction of the lid margin at the mucocutaneous junction was lost. Although we can see laterally that some of the meibomian glands are preserved, and there was some yellowing as well. So can dry eye happen unilaterally? Yes, if the lacrimal gland is involved in some way, that is with a tumor, or if it's removed, or if there's chronic inflammation or a chemical injury. And even chronic conjunctivitis can develop secondary to a dacryocystitis, chronic canaliculitis, or even a diffuse OSSN can present this way. The reason we ruled out floppy eyelid syndrome and OCP was because these are predominantly bilateral, and they can be asymmetric, however, but OCP we could rule out because there was no symblepharon or any pharyngeal shortening noted.
So when the patient came to us, we know that sebaceous gland carcinoma masquerades as blepharoconjunctivitis, chalazion, etc. So we did think of this as a provisional diagnosis. And because of its velvety papillary appearance, we decided to think of a pagetoid spread being involved as well. So the first step was to do an incision biopsy, in which we found that it was a moderately differentiated sebaceous carcinoma, and it was more than 20 mm in involvement. So we labeled the AJCC stage as well. And because the anterior lamella was not involved, we decided to go ahead and excise the posterior lamella with a margin clearance, and doing a map biopsy as well because of suspicion of pagetoid spread. So here we are marking out 4 mm margins as well as on the conjunctival side. And once the lesion is completely excised, we also went ahead and took the map biopsy samples. So once we took the sample, you can see here the anterior, the posterior, and the deep margin is present in the sample. And the map biopsy definitely helps to plan any subsequent treatment. So we found that the margins were free of tumor and that the map biopsy was negative. So what next is that a reconstruction needs to be planned. The posterior lamellar support is required. And any lid sharing technique such as this would cover up the ocular surface, which we did not want. So these are the various options using preserved sclera, which is elastic and biocompatible but lacks long-term structural support, a mucous membrane, which is soft but again undergoes shrinkage and contraction, and hard palate, which has some donor site morbidity, and lid sharing, as I mentioned. What we went ahead and did is we placed an AMG there and went on to dissect a periosteal flap, which was connected there as such, and took a free tarsal graft from the upper lid and sutured it onto the lower lid there. And 6 weeks later, this is how the gentleman appeared. So when we do a posterior lamellar resection, this procedure has significantly less number of surgical procedures to achieve complete tumor control, as has been studied before. And it is also associated with fewer orbital excentrations, fewer metastases, and better preservation of visual acuity. This is another option, that is chemo reduction with 3 cycles of neoadjuvant chemotherapy with cisplatin or carboplatin and 5-fluorouracil. And post any procedure after neoadjuvant chemotherapy, external beam radiotherapy can be used as an adjuvant. In cases with T3 tumor stage, the tumor recurrence is more common, and it has a high incidence of regional lymph node metastasis as well as systemic metastasis, which has been studied at 5 and 10 years. And death due to metastasis is 30% and 50% at 5 and 10 years respectively. So what this case taught us is whenever a long-standing blepharoconjunctivitis, whether unilateral or bilateral, we should look for distortion of the eyelid margin, take a biopsy, and when possible, do a posterior lamellar resection, and reconstruction can be done with a free tarsal graft. Thank you to my mentor, and thank you to Dr. Sampath and Dr. Senthil for this opportunity.
Are there questions now from the? I don't see a lot of questions on that. It's a very
there was one question about, given possible further surgery, should tarsal graft be taken from the other side? A question from one of our oculoplastic surgeons in the United Kingdom.
So I would say
particularly because there is a chance of further surgery, let's leave the good eye alone.
I agree with you, but it was a question which I have just put across what came through the chat. Thank you. We're running a little bit late. Can we carry on and stick to time as much as possible, please? Thank you.
Dr. Bipasha for the next speaker. Can we invite?
Yeah. Dr. Niranjan Karthik will be presenting a case of rhinosporidiosis from RIO GOH. This is the second oldest hospital in the world, next only to Moorfields Eye Hospital. Mr. Collins know about this. Dr. Niranjan.
Am I audible, ma'am?
Yes, you are.
Good afternoon to one and all. I'll share my screen right away. Is my screen seen, ma'am?
Yeah.
Good afternoon, good evening to one and all present here. So I am Niranjan from Regional Institute of Ophthalmology, Chennai. And today we're going to unravel the mystery behind a chronic lid swelling that we had come across. So this was a case of a 70-year-old lady who presented with a growth over her left lower lid for past 2 years, which was slowly progressive in nature. There was no history of pain, watering, or discharge from the lesion. She had a history of both eye cataract surgery done 5 years back, and there was no history of any systemic illness. The examination of the left eye anterior segment revealed a red fleshy sessile mass located about 9.5 mm from the medial canthus of the size 10 into 9 mm, extending from the anterior to the posterior lid margin, encroaching on the palpebral conjunctiva with inflamed edges. But evidences of malignancy clinically, such as that of loss of cilia, were not quite present. The fundus examination was normal in both eyes, and the visual acuity was recorded to be 6/9. Syringing revealed patency of both the lacrimal drainage systems. So from the clinical picture, we had the following differential diagnosis in mind, of which the squamous papilloma and carcinoma topped the list, following which we had other differentials like chronic infections, hemangioma, etc. in mind. So routine pre-operative investigations, including fasting blood sugar and total blood count, was done, which were all within normal limits. Further, the patient was taken up for surgical excision of the mass, and the tissue was sent for histopathological examination. The histopath report showed hypoplastic squamous epithelium, and in the subepithelial region, many thick sporangia containing spores of Rhinosporidium seaberi was noticed, accompanied by mixed leukocytes in the stroma. So on the left-hand side, you are seeing the low magnification showing characteristic sporangia containing spores. And on the right-hand side is an enlarged view of the same tissue specimen to enhance the visualization of the spores seen within the sporangia. On further probing, there was a positive history of habit of having bath in the ponds, but there was no history of epistaxis or nasal obstruction. In order to find out the immune status, VDRL and ICTC was done, which were both negative. The patient was referred to other departments like ENT, dental, and gynecology to rule out other foci of infection, but there was no such involvement. After histopathological confirmation of this particular infection, complete surgical excision was done along with chemical cautery with that of povidone iodine. Following that, medical treatment was initiated with dapsone 100 milligrams once a day for 2 months, which was given to reduce recurrence, and periodic follow-up was advised. So let's discuss a bit about this case. Rhinosporidiosis is a chronic granulomatous disease caused by an endosporulating microbe belonging to this classical group called as Mesomycetozoa. This is actually a group which is very peculiar because it lies at the boundary between that of the fish and fungi, and the organism in this group is Rhinosporidium seaberi. This disease, as far as its geographical distribution is concerned, occurs in Southeast Asia and South America and rarely has been reported from Africa and Europe as well. In India in particular, many cases have been reported from West Bengal, Bihar, Orissa, Maharashtra, Madhya Pradesh, Southern Tamil Nadu, and Kerala. The most common presentation of this disease is that of a soft polypoidal pedunculated mass, and the most common sites involved are nose and nasopharynx, accounting for about 81% of the cases. Other sites include eyes, maxillary sinuses, and urethra. As far as the eye is concerned, the most common site involved is that of the conjunctiva, whereas other sites are lacrimal sac, the canaliculi, and eyelids and sclera as well, which accounts for just 4%. Rarely in severe forms, it can manifest as scleral ectasia, staphyloma formation, and scleral melting can also occur. Now, it is very interesting to note how it manifests differently within eye as itself. In the palpebral conjunctiva, it manifests as red, fleshy, pedunculated polypoidal mass with multiple pale yellow dots, which represent the mature sporangia on the surface. Whereas in the bulbar conjunctiva, point to be noted is due to the flattening force of the eyelids, it tends to be more sessile and flatter in appearance. Whereas in the eyelids, it mimics a tumor and has a very fleshy growth. As far as the infection modes are concerned, the contact of the traumatized epithelium with contaminated water is said to be the most common, and even inhalation of the field dust contaminated by the feces of infected animals can also cause. So to arrive at a diagnosis of rhinosporidiosis, clinically it is possible with the help of the characteristic appearance of yellowish pinhead-sized spots on the surface, which are suggestive of the underlying mature sporangia. But to arrive at a final definitive diagnosis, thick wall sporangia containing numerous endospores in a background of fibrovascular stroma on histopathological examination is crucial. So to conclude, I would like to say that rhinosporidiosis should be considered as one of the differential diagnoses in eyelid swellings, especially in endemic areas, in an infection from, especially with the history of infection from a contaminated source like that of water bodies, even in the absence of infection in most common and contiguous sites like nasal mucosa. So these were my references. And I would like to thank all the panelists for giving us this opportunity to present this case in this wonderful platform. Thank you.
Thank you, Dr. Niranjan. I think rhinosporidiosis is very common in this part of the world, that is the southern part of the world, as you rightly pointed out. And what I had, one question was there any bleeding, or you did mention about epistaxis, but these tend to bleed a lot even on just touching it. Did you encounter any bleed on the table as you were excising it?
No, actually, there was no such evidence of bleeding, which was actually going more in favor of our diagnosis. And at the end, we had a definitive diagnosis to our surprise in the histopath examination. So we did not have that polypoidal mass, which specifically bled on touch. So that characteristic feature was not there.
All right. Are there questions? Dr. Bipasha, anything that I don't see any questions?
No, you have covered everything, I think. And thank you, Dr. Niranjan. You seem to be on duty. Take care. Stay safe.
Thank you. Thank you, ma'am. Thank you so much.
It's a pleasure next to invite Dr. Ganga's team.
Dr. Dinah?
Yeah. Hello. Hi. A very good morning. Thank you for the opportunity to present an interesting clinical surgical challenge for your expert opinion. A 19-year-old female presented with bilateral ptosis since birth and wanted surgical correction for it. At presentation, her best corrected visual acuity was 6/6 in the right eye and 6/7.5 in the left. Her margin reflex distance, MRD1, was +1 millimeter in the right eye and -2 in the left. Levator function was 8 millimeters in the right and 4 in the left. Her full-face clinical photograph showcased obvious frontalis muscle usage, especially at the left side. We also noted a 10-prism diopter hypotropia of the left eye, but stereopsis was preserved. Bell's phenomenon was intact. There was no Marcus gun jaw winking phenomenon or other synkinesis. These were the photographs taken at up and down gazes. In summary, we had a female who presented with bilateral congenital ptosis, left worse than the right, with possible monocular elevator deficiency in view of the hypertropia. Her levator function in the right was moderate, but poor in the left side. These were the management options that were contemplated for her. First, conservative treatment with observation. Second, we could correct the left hypotropia first, followed by ptosis correction. Or third, ptosis correction could be done alone, be it unilateral or bilateral ptosis correction, with the following approaches. We eventually proceeded with bilateral levator resection, maximal versus supramaximal approaches. Surgery was done under local anesthesia in view of her age, with left supramaximal and right maximal. This is the intraoperative photograph, and we can see the fatty infiltrated levator. We used 3 6-0 ethibond sutures. At the post-operative period, week 1, these were her clinical photographs. Of note, there was leg ophthalmos of 3 mm in the right eye and 6 mm in the left eye. MRD1 was plus 4 mm bilaterally. There was, however, peaking of the left upper eyelid margin. Left eye also had poor Bell's phenomenon with some exposure keratopathy. Over email, she sent this photograph expressing concerns of recurrent left eye ptosis. An erythematous lump was present at the left upper eyelid, and a pimple developed at the root of her nose. This was not there prior. Oral augmentin was commenced to treat possible underlying infection. A week later, pus started discharging from the pimple, and the cultures that were sent were negative. Augmentin was switched to cloxacillin for possible skin infection. The pimple eventually resolved at 2.5 months post-operatively, but the left upper eyelid swelling persisted. We went ahead with intralesional triamcinolone administration to the lesion. This is a clinical picture at 3 months post-operatively. There was persistent left-sided ptosis with MRD1 of -1 mm. Decision was made for repeat left supramaximal levator resection, which she underwent 4 months from the first surgery. Of note, she developed inverse Bell's phenomenon, which resolved 1 week from the second operation. The below photograph was taken during her last clinical visit with a final MRD1 of +2 mm in the right eye and +1.5 mm in the left. To emphasize on the inverse Bell's phenomenon, we also had another young boy who presented with left simple congenital ptosis with poor levator function. He underwent left supramaximal levator resection, surgery, and developed inverse Bell's phenomenon post-operatively, as seen in the clinical picture on the right. We have a video showcasing the inverse Bell's phenomenon post-bilateral frontalis suspension surgery. He also had bilateral leg ophthalmos. We would like to bring up the following points for discussion. Firstly, for the 19-year-old lady who developed the left eyelid erythematous lump post-operatively, was this just a case of late post-operative infection or inflammation? If the swelling persisted with induration but no tenderness, was there a role for intralesional steroids or wound exploration? Would you consider revision surgery, and if so, at what duration post-operatively, and what technique should be used? We will also appreciate your comments on the mechanism and etiopathogenesis of inverse Bell's phenomenon. Thank you very much.
Those are very good questions and very interesting scenarios. Maybe I would request Dr. Rose, if he's around, to give his comments. I don't see him. So the first case had a fatty infiltration of the levator.
It wouldn't unmute. It's interesting. I think it was a lovely presentation. It looked very like a low-grade infection. And one thing that stuck out in the history early on, which would increase the probability that it is infective. Did you say you used ethibond? In other words, a non-soluble suture for the ptosis repair?
Yes, we use 3 6-0 ethibond sutures.
Yeah, ethibond is braided and I think has a higher rate of infection with Staphylococcus, just very low grade grumbling infection. And sometimes when you explore that sort of lump, you'll find the suture is a focus for a chronic inflammatory response with or without a few granulomas around it. You take out the suture and it settles down. I always reassure the patient, once you've taken out the suture, just wait and see, because a little bit of extra inflammatory activity equals a stronger union, a bit more fibrosis. So it's one way of keeping the patient happy whilst you wait and see what happens. But, you know, nice cases. As for the etiology of inverse Bell's, a great video, but I have no idea how it works. Thank you.
I think suture technique seems to be so variable in various parts of the world. We used to use Ethibond for LTS when we were young men, and then we moved away and started using Vicryl. Some use Proline. There are some still use silk for ptosis. So I don't know. I moved to completely to Vicryl, and I feel that's a better suture.
Agreed.
Your opinion?
We used to see the granulomas, Ron, at the lateral canthus where you use Ethibond. Exactly like that, grumbling granuloma.
We used to use the Ethibond sutures for the frontalis sling as well earlier on. Then later on we moved over. And we used to see a lot of granulomas again with the Ethibond suture.
I do use Vicryl only for most of my cases, except where I'm doing supramaximal surgery or where I'm doing a Whitnall sling. There I may use Proline at times. No logical reason, but possibly because I think the late undercorrections are quite common, and to avoid that, I started trying that.
But to be honest, Ashik, do you think that the suture loses its efficiency? If you're really having to put a heavy load on it, you'll get a neutrophil response, which causes cytolysis and loosening of the suture, whatever the suture material. So, as you say, there's no real logic to using a permanent suture. Even steel will relax off and lose its effect, which is why I'm more and more, like Ron, moving to soluble sutures, because I think they do get contaminated, Ethibond, with its braiding.
Can I make a comment, please? Can you continue discussion? So what I'm going to say is we'll have a 5-minute break before we start the next session, but excellent discussion going on. Carry on before we get the next two chairs coming in to start the next session. I know we are running a little bit late, but we'll give a 5-minute gap. Thank you. Carry on with the discussion, please.
Thank you,
The
Mr. Sampath.
undercorrections are so common with the poor levator action cases with supramaximal surgery, and some kind of an edema also is more common with the so-called supramaximal surgeries that are virtually given them up, and I would have preferred a primary sling in that case. Of course, the eventual result was very good with a repeat surgery, but I would be chary of doing it and would possibly have done a sling in the first place, possibly a bilateral fascia lata sling in both the eyes.
Yeah, the other thing that was quite noticeable was how much lag ophthalmos and hang up the lady had before surgery. You really, as you say, are pushing the limits of what the front of the eye will tolerate, especially if they're weak bells. And this lady, of course, had the weak elevation of her left eye. So she's the nightmare of all nightmares for really getting a good result. You cannot make a silk purse out of a sow's ear.
True.
So how about the inverse bells that have you ever come across, the Grovosa?
Yes, we all do come across it, but it happens when it happens in a supramaximal surgery. Maybe it has a logic that you are getting close to the area of the superior rectus and possibly altering something. But it happens in other cases as well. So we don't really have a rational explanation today.
Can I ask a silly question, because I don't know a lot about it? Is this a new phenomenon that you only see after surgery? Or do you think they've always had a down gaze bells? Because I studied bells like 30 odd years ago and wrote several papers on it, which showed that there's a big variation between normal people. Most people are up and in, whereas others, there are occasionally down gaze bells phenomena. It's published in Eye back in 88 or something. So do you think it's long-standing and it's just more marked after the surgery? Gango, was it your patient, wasn't it?
Yes, Mr. Rose, thanks a lot for your comments. I was hoping to pick on David's and Professor Collins' brains as well. And I incidentally had discussed the first patient with Mr. Collin when all this happened. And one of the theories that we came up with was exactly the suture material going through the tarsus, the meibomian gland. And when the sebaceous glands elsewhere in the face flared up, simultaneously there was a foreign body in the meibomian gland in the tarsus, which provoked an inflammation rather than an infection. I thought it was an infection, never went away. It was a chronic inflammation until that suture material came out eventually. Coming to the discussion, I'd like to hear more about the inverse Bell's phenomenon, the pathogenesis. One of the things which has been proposed is the levator superior rectus complex. And anytime you're doing a traumatic procedure supramaxillary, it is basically an intraorbital surgery. You are further kind of weakening the superior rectus and disproportionately activating the inferior rectus even more. And that has been proposed. Thankfully, most of the cases I've seen, the inverse Bell's phenomenon has resolved. But I had this one patient who had a bilateral frontalis suspension done donkeys years ago somewhere else, hardly any symptoms, but it is remarkable how he could carry on the rest of his life with bilateral inverse Bell's phenomenon.
So it is.
Is there any? So carry on.
In the first place.
It is
Sorry?
also found sometimes we see the inverse Bells in the normal cases also. So what do you think that could be the cause in normal cases?
I think any traumatic dissection causes a disproportionate action and function of the inferior rectus compared to the superior rectus. And I mean, that's the only thing I could think of. And I'd actually get everybody's input on how often do they see it? Does it go away? Does it persist? And maybe we should put all our cases together.
I've seen some cases in frontalis sling also. I think I've seen 1 or 2 cases where there was an inverse, but I think it resolved by itself over a period of time. So
I think all depends on how deep you go between the superior rectus and the levator, and there is a common sheath between the two. My personal opinion, as long as you don't dissect the common sheath, there is very little risk of damaging elevation of the superior rectus. But there will be some amount of damage if you go really deep underneath the levator to really bring it up forward. Maybe there is mild damage to the superior rectus, and there is a secondary herring-like phenomenon, as Ganga pointed out, to the inferior rectus. I don't know.
I think, Ron, you're quite right about preserving the common sheath, but let's be honest, you're letting off a hand grenade when next door you're operating on levator, and so inflammatory cells and so on will have a transient influence on the neighboring levator, superior rectus. And so as Ganga says, it may just be a temporary phenomenon, but there are some normal people with downgoing bells. And I just wondered, do these always resolve to go back into an upgoing bells, Ganga? I don't know. I've not really seen this phenomenon.
Yeah. Yeah, I mean, it's quite challenging. It's alarming when you see it, especially in a child for the first time, and the parents are wondering, what on earth did you do?
Yeah, no, it's spectacular video.
Thank you.
Nice publication in ophthalmology where they have shown a case which developed inverse Bells after frontalis sling surgery, and the only mechanism they could postulate is that sometimes in a sling surgery it might cause too much of bundling of the tissues, and this might cause an indirect trauma like edema and hemorrhage in the muscular and subvenous plane, and this might lead to a Bells. So there are some reports of inverse Bells even after the sling surgery.
So did that get better, Kasturi, by itself, again, suggesting edema inflammation?
it does get better. I think it does get better, yeah.
Interesting, thank you.
Thank you very much, everybody.
Thank you so much.
Can I comment?
A wonderful case.
Ganga?
Hawate
Yes.
is online. Hawate, you would like to make any comments?
I think, well, the exact mechanism underlying the Bell's phenomenon is unknown, but possible explanation is the reciprocal muscle activity of the superior rectus, the levator palpebrae, and the orbicularis oculi with innervation from the trigemino-oculomotor nucleus, and the variation in the Bell's phenomenon, which is reduction or inversion following eyelid surgery, can be seen in residual ptosis, ptosis with myopathy, and congenital complicated ptosis. But usually, I've had a patient, but usually this is transient from my experience.
Ronaldo, it's lovely having you on. For people who don't know, Dr. Hawate is a very senior lid, lacrimal, and orbit surgeon. He's done a lot of work on lacrimal apparatus. He works out of Philippines, and he travels to England quite often. Thank you very much.
And an important point, if I may add, he's the founding president of our Asia Pacific Society. And by him being present at the webinar, all of AP Sopris is here, Raghavan.
Thank you very much.
Thank you also.
Okay, can we move on to next session? Can I invite Joyce Burns, who's a colleague of mine, oculoplastic surgeon at University Hospitals of Leicester, and she runs the eye casualty at Leicester and provides fantastic oculoplastic service. And also lovely to have Professor Harpreet Haluwalia from Coventry, who runs the oculoplastic service in Coventry. Can you please take over chairing the next session, please? Thank you.
Thank you, Good morning, everyone. Good morning, and thank you, Raghavan, for organising a fabulous session. I'm sure everybody's enjoying it as much as I am. And good morning, Harpreet.
Good morning, Joyce.
Can I introduce the first one? It's a presentation from Jeremy Bowyer's team. Jeremy is based in Stoke-on-Trent at the University Hospitals of North Midlands. And the presentation is on gaze-evoked hemifacial spasm by Dr. Pereira. Would you like to start sharing your screen?
Am I heard and is my presentation is shared?
Not yet. Not yet.
Is it?
Not yet.
It was working fine when we tested it, so it should be all right. You are on share. You should be able to share.
Oh, there we go.
Yeah.
Thank you. This is a presentation of gaze-evoked this is a case presentation of gaze-evoked hemifacial spasm in a 33-year-old female who was presented to us with a chronic headache and twitchy involuntary movement of the right side of the face, which is suggested to be a hemifacial spasm, mostly on the right gaze, and with an occasional diplopia on lateral gaze and a bothersome ear ache. Obviously, she had a pretty complicated past medical history with a headache since the age of 19, which was not very well responding to the analgesia. However, under neurologic care, she was diagnosed to have chronic migraine without aura with analgesia-related headache. There's an incidental finding of unconvertible degenerative process and C6 root canal stenosis. However, at the same time, she had some dental problems with ended up in a dental extraction and a TMJ splint for persistent TMJ pain. And also she had an impacted right upper molar tooth, which was not intervened. Finally, she was left with left maxillary neuralgia, which was managed medically. However, at the end of 2013, she was at the beginning of 2019, her migraines were worsened and she was introduced with botulinum toxin regime. Fortunately, her migraines were well under control after successful treatment of botulinum toxins after 3 sessions. However, unfortunately, she developed some ear problems at that time with some ear ache and ear fullness, which was seen by 2 ENT surgeons that they thought it is due to the impacted wisdom tooth. However, the MaxFax team could not find any correlation with that. Anyway, the ENT team saw some inverted tympanic membrane, so they are planning on putting her on grommets. And by the time she came to us, she was having a worsening retrobulbar and peribulbar kind of a pain and worsening spasm around his right side of the face on right gaze, and worsening of the ear ache, which has given her suicidal thoughts and was managed at a psychiatric unit as well. And on examination, her vision was perfectly normal color vision, normal visual fields, no RAPD, no anosognosia. She has a little bit of prominent eyes with an exophthalmometry of 21 millimeters. However, the retropulsion was normal, no fatigability, anterior segment, posterior segment examination with fundal examination was normal. And saliently on right gaze, she had a spasm, mostly in the right lower lid and in the upper cheek. And in orthoptic assessment, there was an intermittent diplopia in either lateral gazes and a subtle abduction deficit in the right side, which was not very well seen on examination, however, very well depicted on his chart on repeated occasions. This is a video of her. On levo version, there was no much movement. However, on nothing in the down gaze. And on the retro version, there was spasms developing on the right side of the face. And there was nothing observed on the left side, so it's more towards a hemifacial spasm. And on duction studies, it was pretty much similar. On levo version, there was nothing. On abduction of the right side, there was twitching developed around the right eye. So in the levo version, there's nothing again on the left side, and twitchy movements on the right side. So investigations-wise, the basic investigations were normal, and we looked about the thyroid profile because she has prominent eyes on altogether, and also because of this diplopia transient. I mean, we looked at myasthenia gravis as well. Everything came as negative, and the MRI studies, MRI head and orbit with contrast was normal. And on discussion, this was the only case that we could find with hemifacial spasm that was provoked by lateral gaze, which was in a 78-year-old man who has sort of comorbidities with a past history of transient conjugate right-sided gaze palsy, having hemifacial spasms. At that point, they could find periventricular leukoencephalopathy with ischemic microangiopathy, mostly in the pontomesencephalic junction in the lower pons with a special MRI sequence. But in our case, it was a young patient with no comorbidities, and the MRI was essentially normal. Well, of course, this has been a synchronicity. The facial synchronicity is very common in the different part of the same nerve, and it is documented to have between different nerves in facial trigeminal and facial oculomotor nerves. But this was the only case before us. I mean, it was reported as facial abducen synkinesis. Well, the postulated mechanism would be aberrant regeneration, creating artificial synapses and effective transmission between the poorly myelinated or damaged nerve fibers, because the gaze center in the parapontine reticular formation in association with the abducen nucleus with the fasciculus or the nucleus of the facial nerve. So in our case, of course, we are not very much sure whether this is a central or a peripheral phenomenon because she was having a lot of problems in her right side in particular. It raises possibility whether this is a synkinesis between the intraaxial or extraaxial facial and abducen nerve. However, there was an obvious gaze-evoked hemifacial spasm in her case. And there we did look at the neuroimaging, which was normal at the abducen nerve, facial nerve, and cerebropontine angle, and the vascular root entry at the cerebropontine angle. So since that the hemifacial spasm with 6th and 7th nerves was not very well documented, is there any similar experiences among the audience? And at the same time, we have already referred her for our local neuro-ophthalmology opinion. Or is there any valid other investigations or detailed imaging that would be helpful in our case? And also the traditional botulinum toxin would work in the similar way in this situation. Thank you.
Okay, we've already got 2 questions on the chat. I think the first one is from Tristan McMullen. His question is this a variation of Duane's?
There was no retraction of the globe that we could see. And in fact, our pediatric ophthalmologist saw the patient. And on orthopticity, there's no esotropia or exotropia that was seen.
But presumably this is all acquired. She hasn't had this all her life, which would...
No, it was very acute. It was just early this year that she developed this.
I mean, the area where the 2 come together is the facial colliculus, where the facial nerve fibers wrap around the abducens nucleus, and it's most likely that you've got an electrophysiological spread in the brainstem causing the synkinesis, and it's, you know, fascinating case. And that leak can be so small, you may not see it, like a small demyelinating plaque. You may not actually see it, and presumably it's a microvascular level. But interesting.
Yeah, I think that was what our concern was when we saw that case. The letter was that the patient may have a sort of an infiltrating brainstem tumor or demyelination or some kind of neuroinflammation, and that maybe our scanning hasn't been adequate. Because I know some things can be very difficult to sort of pick up, you know, the classic sort of neurosarcoids and things like that.
The other thing is you need a critical size, and you are talking, they are so close together, the 7th and the 6th cranial nerves. At that point, you know, they're just right next door. So you may see absolutely nothing, and it may be a static phenomenon. You know, she's had something that's allowing electrical leakage between her 6th and her 7th. But it's very interesting.
Thank you, Dr. Pereira. I think our 10 minutes are up, so we'll move to the next presentation for Joyce to introduce, please.
Okay, our next presenter is from the Shrewsbury and Telford Hospital Trust under the care of Dr. Sagili, and it's orbital abscess presented by Dr. Dillon, please.
Is it up and running, and can everybody hear me?
Yeah.
Great. So thank you to all panelists and speakers from around the world. I'd like to share an interesting case we recently encountered locally of a 21-year-old male who presented with a 2-day history of right-sided brow ache that progressed to diffuse periocular pain, redness, and swelling. This occurred on a background of a 5-day history of right frontal sinus pain with associated nasal congestion. There were no other known medical comorbidities. On examination, there was marked diffuse periocular edema and erythema involving both the upper and lower lid on the right-hand side. Consequently, examination of the right eye was significantly hindered, resulting in an inability to reliably determine optic nerve function and ocular motility at presentation. We felt the clinical picture was strongly suggestive of orbital cellulitis, and hence the local protocol for this condition was commenced. Our protocol is a fairly standardized protocol that you would encounter in most units internationally, and it consists of prompt commencement of intravenous antibiotics, baseline serological investigations, concurrent ENT assessment, and CT imaging. CT scanning of the orbits in coronal section shows pansinusitis with associated with a superior subperiosteal abscess and infralateral displacement of the globe. Our ENT colleagues on the day of admission performed sinus drainage and attempted to drain the superior abscess as far as possible through a Lynch incision. Following ENT surgery, the upper lid infective collection persisted, and repeat CT imaging revealed an intensification of the superior subperiosteal abscess, necessitating drainage through a subbrow incision. So just a bit now about the various approaches to draining such abscesses. There are a variety of incisions one can make depending on the location of the abscess. The underlying principle in all of these instances is to dissect down to the periosteum and lift the periosteum from its underlying bone, and thus facilitating drainage of the necessary abscess. Following drainage, the patient tended towards a complete recovery and made very good progress on all antibiotics. Unfortunately, despite the apparent success of the initial surgery, he represented 4 weeks later, again with upper lid signs. Repeat CT imaging showed far better aerated sinus, but a recurrence of the superior subperiosteal abscess. The abscess was drained again through a subbrow incision, and a vacuum drain was left in situ for around 24 hours. His initial surgery, a corrugated drain was used. We felt it was very unusual for an otherwise healthy 21-year-old to present with a recurrence of a superior subperiosteal abscess so soon. Therefore, his immune status was also checked and came back negative. Streptococcus aeruginosus was cultured, and he was treated with IV ceftriaxone followed by oral clindamycin. 2 weeks following the second drainage procedure, he has made a complete recovery, or so we hope. Thank you.
Amrit, there are two main themes of questions. So one is, why did you not use a skin crease incision as opposed to a subbrow incision? That's one question. And there's another one from David about always suspect a retained foreign body.
Yeah, so from my understanding, a subbrow incision was used because we felt that it facilitated better access to the anatomical space that we were interested in. I was present for the first surgery, and it worked very well in both instances, and in both instances resulted in a sufficient therapeutic effect. So I think that was more of a surgical preference. And
the eyelid was significantly swollen, so if I expected to go a subbrow, which would give us direct access to the subperiosteal space.
Okay, and then there's a question from Jeff saying this is an unusual organism.
I don't think unusual organism. If you've got recurrent abscess, low grade, odd organisms, sometimes things like you can get unusual mycobacteria can present, although this is a bit acute in its presentation. The only downside to the subbrow incision is it's a bit like presenting, a cake on a silver plate. That scar remains visible really for quite a long time. So I do tend to favor upper lid skin crease incision. It's like the Lynch incision. It really leaves a very obvious mark on patients. So I tend to try and avoid it, Suresh.
And most people would put a vacuum drain. Jeff, would you still use a corrugated drain?
Yeah, I tend to, because you can take it out at 24 hours. It's really a matter of getting the organism under control. But a recurrent collection, you either think they've not drained the sinuses adequately and it's re-erupted through where it went before, or you've got something funny in the way of an organism that's left over from what went before.
Mm-hmm.
I would like to add that, yes, for a superior orbital approach, we always try our best to use a skin crease approach. And for inferior approach, always try our best to use conjunctival approach, exactly for reasons pointed out by Jeff about scarring. And the other issue is where you expect hemorrhage, which I rarely put a suction drain in, mini-vac, but where you're operating abscess, I think it's better to place a corrugated drain rather than a suction drain. In one case, I didn't put a corrugated drain because I thought it was a small abscess, and I will get away with it, but burnt my fingers. So now if I drain a subperiosteal abscess, I always put a drain in, and I always do a corrugated drain rather than a mini-vac drain, which we have access to both. It's not because we don't have access. That's my experience, but I would like others to share theirs, including David Verite.
Yeah, David's made a comment. I was just coming.
I agree with you. I think that both your point and Jeff's are relevant in the sense that you want to leave it open. And the best way to leave it open, if you like, for drainage is to put a corrugated drain in. I think there's a risk of putting a vac drain, and that it can be blocked off by tissue, and then you can have a locus of infection which continues and is not in effect open to the outside world, which a corrugated drain does. So I would advocate personally a corrugated drain. Interestingly, I'm currently giving a witness report on a patient who also presented very, very rapidly with onset of collections elsewhere. And they were found to have a strep Milleri. So it does seem to be that strep Milleri does increase the risk, the propensity for infections and collections. That's not something I'd learned until relatively recently.
Funny organisms, David. There are several of them. The other thing is that the children probably don't need the drain as much as the adults, because children, as you know, have a better capacity to reabsorb an abscess. Full stop. Jerry Harris has shown that they get a much better response under the age of 10. So they may not need a drain left in place.
The other interesting thing, Jeff, once again, is that although the ethmoid sinuses were involved, the abscess was supratemporal, which we see again and again. And you'd always imagine that the collection ought to be but beside the sinus, and yet it so often isn't, presumably for local embolic spread, I suppose.
Okay, I think in the interest of time, we'll move to the next presentation. Joyce.
Okay, our next presentation is from Wolverhampton, Mr. Sandramouli's team on delayed management of periocular complication of hyaluronic acid dermal filler. And the presenter is Dr. Awad. If you'd like to start sharing your screen.
Great. Thanks everyone for the opportunity to present on this virtual platform. And indeed, we'll present this case. So hyaluronic acid-based dermal fillers are very, very common, especially in today's world of aesthetic medicine. And these are the most popular ones which are used. Hyaluronic acid is a linear polysaccharide and has alternating monosaccharides. And chiefly, its main aim, of course, is to maintain dermal hydration. So the aim of this presentation really is to present this rare case of lid migration of hyaluronic acid-based dermal filler. And I'd like to point out this treatment was done elsewhere 3 years ago prior to presenting to our unit for treatment. So this was a 47-year-old Caucasian female patient who had Juvederm filler in 2016, which was injected bilaterally underneath her eyebrows. And she then presented eventually to our unit in April of 2019 after having been turned away from several other units who were not keen on treating this particular complication. So this is a picture showing her anterior view, and it's more obvious on the lateral view I'll show you next, where you just see this overhanging area here of skin with presumed dermal filler migration. So prior to any further treatment, we investigated her with this T2 weighted axial MRI scan, and this shows these bilateral areas of hyperintensity in the soft tissues of both upper lids, and in fact this was anterior to her tarsal plates, and the formal radiology report had concluded that this was in keeping with our suspicions of dermal filler migration. So as a trial treatment, 30 units of hyalase in 0.1 mils of saline was injected into the bulky swelling initially on the right side, and this was done with swiveling needle motions at an angle of 45 degrees. And very pleased to report that at 10 days post her injection, when she was reviewed, this revealed complete resolution of her swelling on the right side. There was, however, a history at day 2 of having noticed crepey-like skin on the upper lid around where the previous bulky swelling was, but this resolved spontaneously. These are her post-hyalase injection images. And particularly, again, the lateral photo here demonstrates that there is resolution of that bulky swelling, and she herself was indeed very pleased with the outcome of this treatment. So we obviously did the same treatment for her left side, and this had exactly the same events, and we resolved the swelling on both sides. So of course there are two sources of hyaluronidase, both bovine as well as synthetic. And the latter has a greater purity and a lower incidence of allergic reactions. The half-life of this treatment is 2 minutes, and the duration of action is 1 to 2 days. She, in fact, lives around 40 minutes away from our unit at Wolverhampton, and on her way home had reported that she, when she arrived home, had noticed the swellings had almost completely settled down. Delayed management of acid dermal filler complication has not actually been reported before, as far as we could see on a literature review. If it is infected, it is important to prescribe antibiotics 1 week prior to treatment in order to prevent potential dissemination of infection before you treat with hyaluronidase. So the volume to inject is usually the number of units required over the total number of units of 1,500, and multiply that by the diluted volume in mils, and this will give you the total volume in mils to inject. The number of units is ascertained from a table which was printed on the journal referenced at the end. To conclude, as I said, there are no case reports to demonstrate the persistence of HA filler migration 3 years following her periocular treatment, and we demonstrate that we can treat such lesions despite this long time frame with HILAs. And importantly, we emphasize the risk of injecting these fillers beneath the eyebrow as the risk of migration is extremely high. Thank you.
I have a question. Can you let me know what type of Juvederm product was used? Was it a Vycross technology or the previous Hyalocross ones?
Sorry, what type of Juvederm?
Fortunately, it was done outside, and we do not know the details other than what the patient told us. She just mentioned it was Juvederm, and it was in 2016. But we do not have the further details.
Because the Juvederm, the initial product, which was the Hyalocross technology, there are multiple reports of migration. There's a report where it was injected in the nasolabial fold and it has migrated into the orbit. So even if it is injected in the brow, there's every possibility of the migration. But however, it is seen with the Vycross technology, this migration has much reduced because of the enhanced G prime.
All she told us, she was a very sensible lady. She told us the concerned aesthetic surgeon did warn her that it's a very unusual area to inject, and there is a significant risk of this migrating into the pretarsal zone. And she still insisted on getting it done and had it right under the brow. In fact, it was just underneath the brow, which is something which we don't normally do.
So just what I was going to ask, Muli, why would a woman, not being sexist at all, but why would a woman go for a sub-brow injections? Us gents have the grumpy brows that stick out and descend. The one thing most women go for is a higher brow with relatively flat profile, or am I missing something in this day and age of gender equality and Lord knows what?
Well, I think
there are some younger generation surgeons who use that a lot for improvement. So I think Kasturi has got a lot of experience.
Well, Jeff, I did ask the patient, why did you say yes for such a risky venture? She said it's because she wanted a higher brow. And that's what was promised as a result of that, which theoretically makes sense.
Will drop it, won't it, Muli?
Pardon?
Adding weight to the brow with a filler will drop it, unless I'm silly.
But it needs to give some amount of volume and some amount of lift. For the lift, we usually use injection botulinum toxin, where we inject into the upper part of the orbicularis. So the frontalis will have an antagonist action and pulls it up. But for the volume, we need to give some amount of filler, and together both the combined effects gives a much better effect.
But would you inject it sub-brow?
Yes, it is sub-brow, but it should be in the subperiosteal area. Maybe it was little superficial, which had led to the migration into the pretarsal zone.
That's what happened in this case, yes.
And another important thing, I just want to highlight an editor because you have managed it very nicely with HILAs. But recently we had seen some patients having injection HILAs. They had ended up with severe reaction to it, especially the type 4 hypersensitivity reaction. So one should always keep in mind wherever we use the hyaluronidase, we should have a steroid with us because they can present either as a type 1 or a type 4 hypersensitivity reaction.
That's useful to know. Thank you.
I mean, if you look at the current concepts of brow ptosis and brow lifts, the brow fat pad is something which is gathering a lot of attention. In the past, we were debulking a lot of brow fat pads, but now we're kind of transposing and filling in the brow area for brow lift purposes, very similar to what Kasturi is mentioning. So it is probably an early attempt at this young lady to have the brow volumized to get the brow lift. But fillers being fillers, and they're regulated fillers and non-regulated fillers, they behave the way they want to behave. And thanks to these fillers, I think we'll always be busy in the periorbital area.
I think we'll move on to our next presentation now. So the next one is from Nottingham, from Katya Tambe's team, entitled Lessons Learned from a Case of Auto-Evisceration, and the presenter is Palvi Badwarj.
I'm sharing my screen now. Can you see?
Not yet, Palvi.
How about now?
Nope.
Well, we tested early in the morning, it was working. So
yeah, it should work. Is it on the screen?
no, we can see you, but not the shared screen.
I'm sharing my screen, so
Just come at lunchtime, your screen.
Yeah, we got it.
Fantastic. Hang on a second. Start slideshow. Is everyone able to see?
Yes, it's working.
Yes, that's great, Palvi. Thanks.
Okay, I'd like to start by thanking the organisers for this opportunity, and I'm going to present a case that I came across whilst working under the supervision of Mrs. Tambe. So I present to you a 36-year-old female who presented to our eye casualty department with pain in her left eye and her intraocular lens having extruded onto her pillow. On examination, she was found to have a visual acuity perception of light in the affected eye with a corneal melt, a disorganized anterior segment and no fundal view. There was a past ocular history of trauma as a child, cataract extraction and lens implant in 2013, and followed by this left retinal detachment repair 2 years later. After this, many years after, she developed an odd vascularization around her lens implant, band keratopathy and a secondary left exotropia, which was subsequently managed with a cosmetic contact lens for 4 years prior to her acute presentation. The patient was seen in the oculoplastics clinic, and on examination, there was an auto-evisceration of the ocular contents. An ultrasound B scan was not performed as the globe was soft and open. The patient was consented for completion of her left evisceration, which was performed in July of 2018, and the contents were sent for histopathological review. Much to the team's surprise, histology was highly confirmatory of malignant intraocular meduloepithelioma, which stained positive for the immunohistochemistry marker LIN28A. The patient was referred onwards to an ocular oncology service for further evaluation of extrascleral extension. A staging CT scan was performed, and she went on to have an exenteration which showed no evidence of residual tumor. In a study of 2009 enucleations, it was found that less than 1% of these enucleations were found to have ciliary body meduloepithelioma. Although it is extremely rare, it is the second most common congenital primary intraocular tumor. It's a tumor of the non-pigmented ciliary body epithelium, which can also arise from the iris, the retina, or the optic nerve. It is usually unilateral in nature and presents before the 10th decade, but extremely rarely it can present in adults and has been reported to account for up to 15% of all cases. 80% of adult cases are malignant, and important differentials in adults are amelanotic melanoma and metastatic carcinoma. It has many eponymous names linked to its histopathological description, and it can be classified as teratoid and non-teratoid, which then can be subclassified as benign or malignant. Non-teratoid types consist of cells that resemble ciliary epithelium, and the teratoid type can contain cells of diverse origins such as cartilage, brain, or rhabdomyoblasts. There are no universally agreed malignant features, but 4 key elements that suggest malignancy are retinoblastoma-like changes, sarcomatous elements, pleomorphism and high mitotic activity, and lastly, extraocular invasion. Immunohistochemistry markers such as LIN28A are linked to embryonal tumours with multi-layered rosettes, but they are not specific for medulloepithelioma. However, its intensity can correlate to tumour aggression and can predict or partially predict tumour behaviour. Most patients are asymptomatic until extensive growth and sequelae develop, but they can present with pain, reduction in vision, and absent red reflex in children. It can mimic other neoplasms such as melanoma and metastases, and the tumour can go unrecognised in up to 50% of patients who have undergone routine intraocular surgery such as cataract, glaucoma, or retinal detachment surgery. This table depicts the most common features that are reported in the literature. Of note, especially with our patient, retrolental cyclitic membrane could have been the odd vascular membrane that was noted, retinal detachment and cataract. Before imaging techniques were available, about 10% of blind painful eyes that were eviscerated were found to have intraocular malignant tumours on review of their pathology. It is one of the dreaded complications of evisceration, along with sympathetic ophthalmia. And it has a diagnostic surprise in evisceration has been reported in up to 0.62% of eviscerations. The favoured imaging modality is usually B-scan, which reveals a heterogeneous mass arising from the ciliary body with cysts and a high internal reflectivity. Further information can be delineated using an ultrasound biomicroscopy. And if there is a diagnostic dilemma, such in our case, other modalities should be used, such as MRI or CT, to directly image, rule out focal or distant spread, and also assist in staging. Although this scenario is extremely rare, the best form of treatment for adult cases is unknown and there's no evidence-based approach. However, most adult patients with a confirmed diagnosis have an enucleation, unless there is extrascleral, optic nerve, or orbital extension, in which case these patients go on to have an exenteration. Other reported treatment methods have been reported in the paediatric population and for smaller tumours. These are globe salvage techniques, which all involve some sort of scleral delamination with tumour resection, and these methods achieve good surgical outcomes in more anterior and smaller tumours and are able to retain good visual acuity. If this tumour is confined to the globe, it has a 5-year survival rate of 90 to 95%. If there is any evidence of any extrascleral extension, it has a high morbidity and mortality. Finally, this case highlights the importance of imaging preoperatively when considering eye removal, ideally ultrasound, but don't forget CT and MRI are extremely useful, and always send tissue for histology. And lastly, medulloepithelioma should be an important differential for adult anterior segment tumours. And I hope that this also echoes a previous presentation that we should always image patients before considering eye removal. Many thanks for your time. And here are my references.
Thank you, Pallavi. Before I open it out to the House for questions, I think there's a comment from Cornelius, and then there's a comment from Jeff and Kasturi. Do you want to start, Cornelius? Can I move on to Jeff, please, then?
Why don't you ask on his behalf?
It says CR, so I'm just guessing it's Cornelius. Was there use of topical steroids, which can result in
we are trying to get him Cornelius. If it is Cornelius, CR, is it Cornelius?
CR is me.
Yes, it is him.
We can barely hear him, yeah.
Yes, I was just asking, was there use of topical steroid in this case? Because I had a case of a spontaneous expulsive once, which was actually due to chronic topical steroid use in a blind eye.
The case came from another hospital to us, so we're unsure if there was any topical steroid use before, but there was history of cosmetic contact lens, which could have attributed to the corneal melt.
And also, of course, the non-steroidals now have been described with, haven't they, with corneal melting, if I'm not mistaken. It's one of those things you have to look out for, or have I got it wrong?
This case was really interesting because she came with a phone call saying, I found my intraocular lens on the pillow, and that's the first time we saw this patient and heard of her. So the history, you know, when you go back and think of it, then yes, you can see that there was this retrolental vascular area and stuff like that. But before that, it just looked like probably it's the contact lens that has irritated the cornea and maybe caused the autoevisceration.
Okay, and there was a comment from Kasturi as well. Is she still here, Kasturi?
Yeah, we also had a case and that also had undergone a spontaneous evisceration, but the patient is on follow-up and like we are managing her. But this is something very sad when it comes to us in this situation. Like nothing much to add to it, just we also had a similar case like that.
Okay, I think we can move on to the final presentation, and there's some time for discussion at the end when they summarize. So can we introduce the last one, please, Joyce?
Yep, our final presentation is from Kettering under the team of Miss Menon, and the title is Ischemic Optic Neuropathy. Oh, sorry, no, beg pardon. The title's been changed to Horner's syndrome, and it's presented by Dr. Vermeulen.
Good afternoon, everyone. I'm Dr. Rupa Vimana, and I'm speaking today from Kettering. Today, my topic is, can subtle ptosis can actually be a clue to life-threatening disease? As ophthalmologists, sometimes we are out of our comfort zone and have to diagnose a disease which has systemic implications. Coming to the first case, he was a 75-year-old gentleman who was referred originally from the eye casualty into the oculoplasty clinic. He came within 2 weeks of referral. He was originally a referral from the optician for ptosis and anosognosia for about 2 months. He was unaware of the ptosis. He did not know about the duration, and he was quite annoyed that he was coming into the hospital second time and he didn't have any symptoms. And on examination, he did have right mild ptosis with anisocoria, which was more prominent in dark. And on installation of 1% apraclonidine, there was a reversal of anisocoria. We went on to perform investigations, and on CT neck with contrast, a large mass was seen in the apical segment of the right upper lobe. He was referred to the lung MDT, who did further investigations, and on whole body PET scan, they found carcinoma, which they thought either had a primary or a secondary coming from the sigmoid. Coming to the second case, we had a 67-year-old gentleman who presented to the eye emergency with a very typical history of painful ulcers. He said he had a severe pain 2 weeks ago. He had to sit down till the pain subsided, and after that he has been having constant headaches, neck pain, scalp pain, all on the left side. He had a left-sided ptosis and meiosis as well. Again, ulcers was confirmed with 1% apraclonidine. Urgent imaging was requested, and neurology advice was sought because it was painful ulcers. Neurology advised urgent scanning. CT angio was done within 2 days. However, no dissection was noted on CT, but MRI angio done 2 weeks later did show a dissection of the intrapetrous portion of the left carotid artery, and there was no stroke. I just have to mention here that carotid dissection can be a diagnostic challenge even on imaging, and it might need more than one modality, and so many times you'll have to go ahead with the presumptive diagnosis and start on antithrombotic agents or anticoagulation to prevent stroke. Coming to the third case, we had a 53-year-old lady with headaches for a month. She was a heavy smoker. Again, left tonus was confirmed with 1% apraclonidine. These are her pictures. You can see left-sided. She was quite painful, and there was a mild ptosis with anisocoria, which reversed on iopidine. We did investigations for her, but we didn't find anything, and we made a neurology referral for further management and investigations. Looks like she had cluster headaches, but sometimes there are case reports with cluster headaches later on having found dissection. Coming briefly touching on the pharmacological tests in honors. Historically, honors syndrome was diagnosed with a cocaine test, and the level of the honors was confirmed on hydroxyamphetamine test. But nowadays we have access only to apraclonidine, that is iopidine, which will diagnose honors syndrome for us. What is our role? Role of ophthalmology mainly is to help with the diagnosis, to arrange urgent investigations, and then referral to the appropriate specialty. Briefly touching on the anatomy, so that you can know where the central preganglionic and the postganglionic honors syndrome would present, and if we know the level, we can ask for appropriate investigation, which is again difficult because there are no tests to identify where exactly the honors would be. Briefly touching on the cause of honors syndrome, in the central causes, we have to think of brainstem disease, syringomyelia, and in the preganglionic, we have to think of Pancoast tumor, carotid and aortic aneurysm, neck lesions, and postganglionic lesions to remember cluster headaches, internal carotid artery dissection, as well as cavernous sinus mass. Coming to the image yield in honors syndrome, we found a paper by Bebe et al. They had 88 patients, and they found a 20% a positive yield in isolated honors, and the most common cause of lesion they found was a carotid artery dissection. Touching on the investigation for clinically isolated honors syndrome, MRI, MRA of the neck and the head, and the neck extending up from the supraorbital ridge to the T4. And as I explained, carotid dissection can present a diagnostic challenge, and early and reliable diagnosis is important to start the anticoagulation or the antithrombotic treatment to reduce the thromboembolic events. Thank you. All done.
Right.
You're muted, Harpreet.
Harpreet and Joyce?
Yeah, sorry, Sampath, I think Joyce has got a question.
Yes, I put a question on the topic of Horner syndrome. What would the panel be preferring to do for a congenital Horner syndrome? A 4-year-old girl whose parents are very keen to have surgery, even though the ptosis is relatively mild. What would be the procedure of choice?
I'd do a Putterman.
I would do a posterior approach, but not cut any tarsal plate, as Tristan suggests.
I would do the same, a posterior approach, leaving the tarsal plate intact and trying not to do much to the conj either.
Can I ask a related question along the lines of Horner syndrome, children and adults? It is not just the upper eyelid coming down. Sometimes these lower eyelids are also riding up, which gives an appearance of a narrowed palpebral fissure, even though the MRD1 is normal. Has anybody done something to the lower eyelid to induce a slight lower lid upside down ptosis correction?
I haven't done anything to the lower lid in my life for Horner's syndrome, my lower lid elevation. I'm happy to make a change to my practice if someone suggests it's a wonderful operation and makes a very good result very fantastic.
I think titrating head elevation would be extremely, extremely difficult.
So I do. So there's theoretically an equivalent of a Mueller's muscle in the lower eyelid. So just as how you describe a Putterman procedure for the upper eyelid, you can do an equivalent of the same in the lower eyelid. And I've done that in about 2 or 3 cases, and restores a symmetry in addition to the MRD1. Just limited experience.
There's also a comment from Dr. CJM Diaper saying, just to clarify, 80% isolated Horners are undiagnosed. The cause is undiagnosed. So that's just a comment. And I think we can bring this.
What you do, is that similar to a inferior retractor sort of recession?
Right. Well, tightening, plication or tightening.
Advancement.
Sorry, yeah. Advancement of the inferior retractors.
I think the key thing here is that you can get some serious carotid pathology. One of our consultant colleagues at Moorfields presented exactly that way with a slight neck pain and a Horner's. And turned out he had an intramural dissection, which luckily went back into the carotid and settled down. But it can be significant pathology.
Sudden onset Horner's with any headache is carotid dissection unless proven otherwise.
Sounds a good idea. At the moment, my pupils are equal, Ron.
Right. Any more questions?
I think can
we move on, team?
Yeah, I think we can close the session, Sampath. And thank you very much for a fantastic meeting. And thank you to all the presenters in the session.
Good work. Fascinating meeting.
Right. We got about half an hour for discussion on anything lid, lacrimal, and orbit. And it's a great pleasure to have Ganga and Tristan chatting the next session, and be prepared for some controversial questions, and we should have a healthy, robust discussion. Thank you.
So, Raghavan, I know this has been said before, but thank you so much for organising a second excellent, second one I've been to. You may have done 10, I don't know, session, and thank you also to the input from Leicester supporting that. And I think the tone has been brilliantly inclusive with both MOPS and BOPS and the Asia Pacific and India. And it's so nice to see so many friendly faces, because of course we've all been locked up. And it's been so nice to have a sort of non-judgmental and honest discussion, much like we have in MOPS. And I think you've managed to spread that out into this wider meeting, which has been great. I've even managed to do it on call. So there you go. So I'm actually being paid. How you go? But I have missed a few because I've had to duck out and do a few things. My only complaint, as I've messaged you privately, was I haven't yet seen the food. I find the current climate with COVID is very difficult, because we've sort of talked into doing telephone and virtual consultations. But I think a reminder that even a relatively trivial ptosis can harbour sight and life-threatening disease is not to be ignored. And obviously, the wider differentials have been brought out, and all the weird and wonderfuls are out there, even if we don't see them that often. We've even had an idea for a case series of these eosinophilic granulomas, so that's going to be an output from this, and we'll clearly credit the meeting for that. In terms of topics, I think the ptosis is a bit interesting one. We didn't really get an answer to the question what to do with supramaximal ptosis surgery, or whether to embark on it at all. And maybe that's something we could explore further, because I certainly don't have an answer to that. I'm wondering whether the wise and the good would help us out there. But it's also been interesting to notice that even the wise and the good and the great and the good don't have answers for everything. And I guess that's a good thing, because it means our field can evolve and change, and we've all got things to learn and stay engaged. So Ganga, is there anything you wanted to take forward?
No, I just wanted to echo some of what you said. Thanks, Sampath, Mohan, and Senthil, and the Indo-UK team. I don't know who's colonizing who nowadays. And good to see a foreign body in the Indo-UK orbit. That's Singapore here. So thanks very much. Like you said, we covered a good spectrum of congenital, traumatic, inflammatory, infective, neoplastic, vascular lesions. So yes, since we have lovely brains, I don't know if Dr. Betharia and Mr. Collin are still around. I would like to pick their brain on this inverse Bell's phenomenon, if you don't mind. We don't want to belabor the point, but it would be good to hear from the two of them. And maybe I'll have each one of the expert faculty mention one learning or point or take-home point, starting with Santosh.
On which case? Anything?
On any case. So I know you have a lot of experience and you've seen a lot of complications here. Something that really was struck you as new and is worthwhile sending a message to the entire crowd.
Well, I think need for imaging before we do evisceration or enucleation. That is one point I would like to make very strongly, because that's been discussed often, but I think it's still not so commonly done. People who do evisceration believe that, it's a thysical eye or an atrophic eye. They believe that there is nothing inside, but actually it may be an anteriorly located tumor. So even a routine ultrasound B scan can miss it unless an immersion scan is done, and it may be a good idea to do even CT scan or MRI if there is a suspicion.
So the point is the eye does not see what the mind does not know. And if you don't think about it, you will miss and burn your fingers. Yeah. Between CT scan, MRI, do you have a preference, or would you just go for the simple, cheap, effective, fast? I know you do B scan ultrasounds, but some of us don't.
Yeah, you can start with a B scan ultrasound with immersion. And if there is any suspicion, if there's a diffuse echogenic lesion, then ideally in a child, I would prefer a CT scan, because then you have to rule out retinoblastoma and medulloblasoma, both of which show calcification, which may not be very evident on MRI. In an adult, when you suspect a melanoma, necrotic melanoma, then MRI is a great idea because it has very specific characteristics on MRI, melanoma. It's hypo on both T1 and T2, which is extremely characteristic, and it can diagnose necrotic melanoma quite effectively.
Thank you.
Ask a question
Grover?
to Santosh.
CT
yeah,
in
sorry.
children.
Yeah, Mohan.
Yeah. No, I
Go
just want to, Santosh, see CT in children and MRI in adults. That's what it's a take-home message.
If you're looking for retinoblastoma and medulloepitheloma, both of which have calcification, then CT may be more sensitive than MRI. But for adults, when you don't look for retinoblastoma and medulloepitheloma, then MRI may be more informative.
Yeah, I mean, MRI can miss melanoma, of course, Santosh, when they're amelanotic and they don't have the T1 shortening, which you can see with the paramagnetic melanin. And certainly I've had people, even radiologists, go as far as to say this isn't melanoma, and it was. Just the growth rate told you, the clinical history. So MRI will pick up most of them, but not the really amelanotic ones.
Dr. Grover?
So Ganga, I'll make 2 points. One related to the question on ptosis, severe ptosis or ptosis with poor levator function. Over the years, I've learned that whenever I work with very poor levator action, I often, in a very high proportion of cases, end up with a recurrence of ptosis at the end of 6 months when I do a levator surgery. So I've shifted my criterion for Burke's levator action to be 6 millimeters or more for really levator surgery to be permanent or to be good in these cases. And therefore, I would do a sling for most of the cases where levator action is less than that. And where I'm working on borderline cases of 5 and 6, I would do a Whitnall sling rather than a supramaximal. I think once the importance of Whitnall is known to us, we virtually hardly ever end up doing a supramaximal, except in those cases where you find the Whitnall is not well defined at all. Otherwise, my first choice in these cases has turned to using a sling procedure, and generally fascia lata is my preference. The second was a more general point that I wanted to make. We had an excellent mix of cases and very educative to all of us. And I was just wondering, could we devise a mechanism to have a mix of some less rare and some relatively unusual cases, so that it would enhance the educational value for our residents and fellows.
Thank you, Ashok, for those comments. I left it to each unit to come up with whatever case report they wanted to. I thought this was more an informal camaraderie, as Tristan pointed out, on sharing our experience. Maybe in the future we can be a little bit more prescriptive than what we did so far. We are all learning. This is a new era of Zooming or teaming. I'm sure we will take lessons from this meeting, and the collaboration, I hope, extends to other specialties as well. Thank you.
Excellent work, Sampath. This has been very, very good.
Superb job, Sampath.
So going on to Usha and Bipasha to a few comments. I know we've had a nice spectrum of solid lesions with a lot of vascular blood supply, suggest to vascular malformations. And I think Dr. Grover also had a wonderful case. Could one of you summarize your principles and concepts of when to suspect a vascular lesion? When would you do a preoperative angiogram? And before you touch the orbit? Usha?
Yeah. Now, I was just looking at all the case range. I think most of us get to see a lot of hemangiomas. And I think we can make do with just an MRI, which is very good for us to go ahead with the surgery. And the other important aspect the other common things that we come across is capillary hemangiomas. I think Bipasha and the rest of the Indian oculoplasty people would agree that the most common one is the capillary hemangioma, and the other one is the cavernous hemangioma. We do see a lot of cases of AV malformations as well, in which case we need to go ahead and do an MRI. The kind of cases that was presented today, of course, is very challenging. And I do agree that it's not going to be very easy to do all the investigations in all of the cases. So we may have to stick to, when we know that these are discrete and easily, you can easily diagnose, probably we would stick to just the imaging. And then you may have to further enhance with the angiograph and all that if it doesn't really help us. So I think the common ones you need to address with just the regular imaging modalities, and the ones where it's diffuse and you cannot come to a definitive diagnosis, like in the cases that were presented today, probably I'd go ahead and do further investigations. But we also have to keep in mind that it's not easy for us to do all the investigations because we're not supported. It is more economics as well. So we'll have to be really judicious in ordering investigations as well.
Yeah, I think that's right. You have to be judicious anyway. But I mean, the giveaway in your basic imaging is either very rapid enhancement on CT, and you're really glowing, which makes you think hemangiopericytoma or otherwise, or alveolar soft part sarcoma, and flow void artifacts if you're using your MRI. You know, if you're seeing flow voids within the lesion, think this has probably got an arterialized circulation.
And also probably the progression of the lesion also would give us a clue as to what imaging modality we might have to take.
Sure, but going for thinking which ones to arteriogram or which are most likely to give you a problem, those two clues, CT, super enhancement, and flow voids will be the ones you really want to think, should I embolize this?
True, yeah, I do agree.
Yeah, and one point to deal with vascular tumors, I would request all of you to get in touch with an interventional radiologist. That's one team you need to include in your team in order to treat any vascular malformation. They are the key to the management.
Well said, yeah.
Changed the management of lesions, vascular lesions around the orbit, as you say, Bipasha.
Yeah, they have some very good...
Mauli and Tristan. Yeah, David, go ahead, please.
No, it's just that the interventional radiologists who work with the neurologists so much have a lot to offer us in our field, as we're discovering increasingly, particularly with some of these occlusant agents, whether it be onyx or PHIL, which is the modern one. And as has been said, really, you really got to make friends with the interventional radiologist. The other thing is just looking at the patient. In these arterialized ones, you will often see a very subtle pulsatility, or if you look at the Myers on the applanation tonometer, you'll also see some very subtle changes in the way that they sort of, you know, the way the Myers change. So they're very subtle clinical signs which will lead you to that as well.
But they have become brilliant at getting interventional. Some of the catheters now, they can get down the central, down the retinal artery and into branches off it, which is just amazing. And it provided the glue doesn't go back uphill. They,
big centers, there are neurovascular radiologists very specialized in coilings in and around the brain and orbit. So I think there are friends in any vascular lesion which is high flow in the orbit. That would be my first port of call.
Ron, you're absolutely right that they're no longer looking at coiling. They're looking at highly rapidly polymerizing agents, which are fantastic because they basically create a glue cast within moments, followed by some heparin. And you can tell if you look at the post-embolization radiology, you can see there's almost no backflow at all. So they're pretty good, as you say, at identifying and putting very specifically placed occlusing agents. We found them to be very helpful with some of our difficult cases.
Absolutely, and most orbital vascular malformations are very rarely only orbital. They often have dual supplies and so on, which is where you need your friendly neuro interventional.
So I'll let Mr. Sandramouli and Tristan, could you make some valuable comments on some of the cases that you've seen, controversial, some take-home messages?
Just one comment.
Yes,
I think, yeah, I just wanted to add this one little thing. The suture material, there was a lot of discussion around the suture material. So I think it's very, very important for us to choose the right suture material to avoid any complications, because it could be such a small issue. It's disregarded often as to the choice of the material. And there were a lot of questions around that. So I think we need to also understand what material is good enough to be chosen for doing the different procedures.
So since you're on the topic, I suppose a majority chose Vicryl, bioresorbable sutures. How many of you use Prolene? How many of you use silk? How many of you use polyester? Just anybody can speak up.
Vicryl is my choice.
We were all brought up on Ethibond when we were doing LTS first time, and then we moved away as soon as we started seeing problems with Ethibond. I always use Vicryl, and yes, I don't have 100% success with my ptosis surgery. I don't think it's to do with the Vicryl, it's more to do with my technique or lack of it.
Anybody using Prolene and silk?
No, yeah.
I use Prolene.
There you go, Prolene.
Yeah. Can I ask, as somebody who started off being taught to use Ethibond laterally for a tarsal strip and now uses Vicryl, I'm thinking more of the high stakes operations when you are suspending a flap in a McGregor, or just say you have some medial trauma and you want to fixate the medial aspect of the lid and you want that to stay in that position. Would you still use Vicryl in those situations, or would you go back to, say, Prolene just to help you sleep at night?
I always do use Prolene for my lateral canthal anchorage or for the posterior anchorage of the deeper crus of the medial canthal tendon, or for my Whitnall sling. So where my life depended on the suture, I would use Prolene.
Can I just say, I mean, it's interesting how long this argument's been going around. It's almost as old as the hills. It's really nothing to do with the suture in most cases, because the tensile strength is the fibrosis that's laid along the suture track. I remember very well a patient who'd had a silicone brow suspension, and he had to have it removed for some reason, and we thought his brow would drop, but of course it didn't drop because it was the fibrosis that's laid along the track. So quite honestly, and the number of times you go into a patient and you find an old Prolene suture which has become very small, it has its worth, but ultimately it's never the suture that really holds, it's always the fibrotic process. And for that reason, I think the world is generally tending to go towards Vicryl for that reason. As Ron said, you know, gone are the days of those Ethibond granulomas, which they were terrible. And it was misplaced logic from the very outset. Fibrosis is what causes the long-term result. Jeremy, the other point that you wisely said, sometimes a Vicryl is not enough, and I'd use a PDS for that lateral canthal to really raise the cheek up to the periosteum, and that does work for a good 3 or 4 months before finally disappearing. But I wouldn't personally use a permanent suture in any of those.
That's the whole point, David. You are waiting for the suture for fibrosis and mature collagen to form at the site where you've put the tissue. And how long the suture will carry on carrying the load is what determines whether it'll descend and you'll get enough fibrosis. So if you want it to be there longer, use a heavier gauge suture, which will take longer to be cleared. The second thing is self-dissolving sutures increase the inflammatory response, which increases your fibrocyte, your fibroblast activation, which will increase fibrosis. So using proline is actually a negative effect, very low reactivity, relatively little fibrosis, and it won't carry on carrying a load. It'll just cut through like a cheese wire. So a braided absorbable suture will give you the most fibrosis if you need that extra fibrosis.
The argument can go on.
Let's move on. Sandra, Mauli, and Tristan. Tristan, why don't you take care of the rest of the points and questions and controversies? Go ahead, lead the show.
Okay, so you're talking to this, Tristan.
Yes.
Yeah, I suppose the thing that came out was about tissue diagnosis and being sure to get your diagnosis straight before embarking on surgery. But as Jeff said, sometimes you're going in, so you need to do an excisional biopsy all along. I don't know whether there are any thoughts. I mean, I know Jeff's got some quite strong views about lacrimal biopsies, but any other places that we shouldn't be embarking on incisional biopsy?
Obviously, pleomorphic adenoma we all know about, and Jeff did raise the point on SFTs, solitary fibrous tumors, but sometimes it's very difficult to excise it. Jeff?
Yeah, I find they generally have a macro boundary to them. In other words, you can follow them macroscopically. The trouble is they vary a lot. Some are really quite firm and will come out nicely, and I use the malleable to handle them rather than any sort of forceps, and they do really nicely. Other ones are almost filled with like toothpaste, and you can start the dissection, you're getting around the back of it, and then they'll start leaking toothpaste out through a small breach in the wall. And that's the ones that, what do you do? They're a soft lesion. You're trying to get them out intact. What I do when that happens is actually suck up all the contents that's breached and cook the area of the wall, diathermy it, where, before going on further to try and dissect them. I don't know that that's the right answer. I've had recurrent solitary fibrous tumors, but it's sort of the best that I think you can offer.
And do you base your radiotherapy on the mitotic activity?
I tend not to send them for radiotherapy because most of the ones we've seen are really low, Chi-67 and so on. But if they get recurrence, then it becomes a different story. They may still have a low Chi-67, but you have to presume they've got microscopic disease.
Santosh, can you address that issue of radiotherapy in SFTs, your specific indications, or do you treat all of them?
Well, I mean, looking at the literature, of course, there are not too many cases, but pulmonology literature, lung SFTs are more common, obviously, than orbital lesions. And learning from that, adjuvant radiation seems to help in reducing the chance of local recurrence. It doesn't guarantee local recurrence, but of course, it reduces the chance. That is in the literature that's been quite substantially proven in systemic literature. As far as the orbit is concerned, when we reviewed all the cases that are published, we also found the same, that patients who are not given adjuvant radiation tended to recur despite what we thought was complete excision. Surgeon thinks that it is complete excision, but there is always microscopic residual that makes it predisposed to recur. So adjuvant radiation is given. And one point was made when we talked about our case that adjuvant radiation actually 6,000 centigrade may cause harm to optic nerve. No, because if you use a very good planning system, stereotactic radiation, in our case, the optic nerve dose could be limited to 500 centigrade, which is minuscule. Optic nerve can tolerate up to 5,000 centigrade easily. And you can limit it by a very good planning system and by collaborating with a good radiation oncologist who understands the importance of limiting the dose to the optic nerve.
Absolutely. I mean, yeah, if you can spare the optic nerve at very low radiation, it just looked on the planning in the talk, but it looked as though the poor optic nerve was in the sort of 90 or 80% zone. but that's, went past fairly quickly. And so it is at risk at 60 gray, if it gets 80% of 60 gray.
Asked Santosh. Santosh, I've got a case of an SFT, which is actually in the superior rectus, and I've biopsied it twice, and that's proven to be the case. I have seen this patient and monitored him for several years, and it, it remains stable, but he's got significant proptosis. Would that be a case for therapeutic as opposed to adjuvant RT?
So if you have biopsied it, then what was the proliferation index?
It's a low proliferation index.
Okay, in that case, you're justified in observing it as long as it is stable. But if it starts growing, then radiation would be one of the options if you don't want to damage the superior rectus muscle.
Santosh, as you rightly pointed out, we discuss our SFTs in the soft tissue MDT, which is, as you rightly said, almost always involves lung SFTs rather than anywhere else from the body. So they give us advice on what to do based on the mitotic activity and repeated scanning.
So while you're in the topic of orbital tumors and orbitotomy, Santosh, you were dissecting in a part of the orbit which I usually am scared of going to. And since you're here, David is here, and Mr. Rose is here, if you're dissecting somewhere inside the intracornal space and you start seeing the pupil misbehaving, what would be your approaches mentally, psychologically, and surgically?
Take the pressure.
I would quickly release the traction, whatever tissue I'm holding, if it's causing dilatation of the pupil. If it's segmental dilatation, possibly that is okay to continue dissecting. But if it is generalized dilatation of the pupil, I would stop dissecting, do an intraoperative indirect ophthalmoscopy and see if there is any change in the fundus. Then I would very carefully continue. And I wouldn't hesitate to, suppose I have to leave that part of the tumor behind, I wouldn't hesitate to call my pathologist for a rush diagnosis with frozen section, intraoperative squash or imprint, and know what kind of a tumor it is. So that if we leave a part of the tumor behind, do we have any substantial treatment modalities to take care of that residual? That's what you should make sure of. So if that is possible, then I would leave that part of the tumor behind if it's causing dilatation of the pupil repeatedly. And I would also give intravenous methylprednisolone.
David?
I would comment on that. I would agree to that. Obviously, pupil changes are a proxy for what's going on in the second nerve. They're not directly indicative, but it does suggest ischemic pressure. And we've certainly seen one or two cases where pressure in the posterior third will result in an enlarged pupil, which will recover. But I think much of it is going to be ischemic and pressure. And the patients, most of these patients will be having some form of prednisolone during surgery, and one takes the pressure off. And the key thing is, of course, is for the observers to always take the pressure off while they're operating and not just to hang in there on the retractors. But I completely agree with what Santosh has just said.
What if it's a perioptic nerve tumor that you're excising and part of the complete excision is going and taking it off, and you end up with a blown pupil, but the vascular circulature to the fundus is okay? Will you proceed or stop and come to fight the battle another day?
I think there are a few things to add. As Santosh says, the first thing when you see the pupil changing is pause and have a think what's going on. Sectoral dilatation, as you mentioned, may well be because you're affecting the ciliary ganglion or small fibers coming forward from it. And if you just pause for 5 minutes, you'll often find that settles down.
Jeff, you're breaking up. Ganga?
Yep.
I think Jeff has got, we can't hear him.
That's okay.
Frozen, so I think.
Okay, can we move on?
Yeah.
Please.
Tristan, do you have any other questions for the experts?
I was just wondering if there are no burning issues, whether anybody's seen any orbital manifestations of COVID in the same way as we see them with herpes zoster. Has anybody around the world seen that yet?
Not yet.
No.
So we haven't seen, we have had some juniors of ours who are working in intensive care, So they've had a lot of patients with conjunctival chemosis and inability to close the eye following proning of the patients.
Right.
So that's been an issue.
But in terms of actual primary pathology, we're not seeing it.
Joyce may add, but we haven't had anybody coming to casualty with a massive conjunctivitis or anything like that due to COVID. No.
We've had a couple of positive swabs, but nothing worse than that.
We have 300 beds in our hospital with COVID patients. We haven't yet had a call for a conjunctivitis in them. We've had some calls for fundus examination and so on, but not really for any conjunctivitis.
Thank God, sir.
The only secondary pathology we've seen secondary to COVID in the orbits are patients who are now starting to take up exercise, running, jumping, God knows what they're doing, and they end up falling down and breaking their orbits, and I fixed a few fractures.
You are absolutely correct. Joyce will agree with me. We had a few more orbital fractures than usual, we think, and this time involves a male and female equally. I don't know who's hurting whom.
Yeah, the other thing we've had is severe conjunctival chemosis from prone patients in intensive care, which I suspect has been common around the world, but no, not directly related to the COVID as such.
In Nottingham, for some strange reason, we've had 3 self-harming patients trying to gouge their eyes out. Never had this before. Has it got anything to do with, staying indoors and patients not managing their psychiatric condition? One was from the prison as well. So that's something different that we haven't seen before.
So it would be kind of interesting for each one of these centers to look at the sample of pathology you're seeing now and the same comparative period last year to see if the spectrum of pathology is any different. And that'll probably give us the answer.
Had a lot of injuries. Yeah. I think lid lacerations and corneal injuries. There have been a lot of injuries when compared to the previous years around this time.
Yeah, same here as well, Usha. And we have also reported a huge number of injuries in the eye and the lids as well during the lockdown period.
Yeah.
That's because of the referral pattern, I believe, because some of the practitioners, in fact, 90% of ophthalmologists are not working. So most of these patients now come to institutes. Otherwise, they would have got distributed across the city.
Probably.
Tristan, to answer your question, I think COVID does affect the orbit very severely, but I think it affects it because patients are not coming forwards for the treatment that they would otherwise have had. I've certainly had one patient who would have had an orbital decompression for thyroid eye disease, but decided he absolutely did not want to have a general anesthetic. I've had 2 other women who have definitely got orbital masses, albeit fairly indolent, who have not come forwards due to their concerns about traveling. So the flip side of the coin is it's actually got a lot of knock-on effects for ocular plastics because patients aren't coming. And we are going to have a tsunami, at least in the British NHS, a tsunami of cancer patients coming forwards. A small proportion of those, of course, will be ocular plastics. So in the answer to your question, in a funny way, yes, it really is affecting us.
I would like to add, David, because what I have found is nowadays I'm getting proper orbits, as you rightly say, orbital tumors, which are quite advanced and they are slipping. They've slipped through the net over the last couple of months. They're all slowly and surely coming bunched up. So I've never seen so many orbital tumors in 1 week as I did last week or week before.
I think you're right, Raghavan. It's sometimes they're not slipping through the net. They just don't want to swim to the net. I mean, they're just not coming to hospital. Even when we ask them to, they prefer not to. And that's going to be a bit of a culture change that's happened in the last 3 months, and we're going to have to undo that. But we, understand the patient. I understand where they're coming from.
My experience is that I'm getting a lot of tumors referred now, a lot more than normal, because the other oculoplastic surgeons at present are not wanting to do them.
So it's just after 2, so we probably ought to wrap up. I want to express my thanks again to the organisers, both in the UK and India, and also it's great to see Ganga. So I'm sure Tony Tars would have been proud of this and would have approved. And I'll just hand back to Raghavan. And on the upside, I guess we're not going to see too many cosmetic surgery complications because there's none of it going on.
Anyway, first of all,
thanks very much, Rod.
I would like to take this opportunity to thank all the panelists, the presenters, the chairs, and the delegates. Being a Sunday, you made very special effort to be part of this. We tried to make it as as wide as possible the net so that we involve as many units as we can for camaraderie amongst us, given the difficulties we are having with the pandemic and not being able to attend meetings and exchange the camaraderie personally. But I'm really thankful to all the institutions in India, Singapore, and the United Kingdom for making such a huge effort. And without all of your support, this meeting wouldn't have happened. And you all of you immediately said yes when I requested you all, including Ganga in Singapore. I would like to hand over the mic now to Sendil and Mohan to say a few words, and we'll conclude. Thank you all very much.
Thank you.
Yeah, thank you, Sampath. I would also like to echo the same sentiments, and all the leaders in the field of oculoplasty, most senior surgeons in India and UK readily accepted our invitation to take part on a Sunday, and all of them are extremely busy now, and it was very kind of them to oblige. And we had such a rich learning experience today from the top people in the field of oculoplasty, and I'd like to thank them once again for taking part in the meeting. Thank you all very much.
Is Mohan still online?
Yeah. Let me confess. Yeah, let me confess that this is the top of the list as far as the webinars during this lockdown is concerned. During this lockdown is concerned, this has been a really very useful, very educative for a non-oculoplastic surgeon like me. It has been really a learning experience for all of us, and a wonderful discussion by the panelists. Wonderful presentations by each and every institute. I think hats off to you, Sampath, and the entire team for coordinating this entire effort. I think it's been a huge effort, and I'm sure we can reproduce this in the future as well. Thank you very much.
And a special thanks to Jeff and Richard for making it such a unique and wonderful experience. The two fathers of lid, lacrimal, and orbit in the United Kingdom and Europe. It was
my special thanks, because I want to say special thanks to Dr. Richard Collin, Dr. Jeff Rose. They have visited Chennai. They have visited Rajan Eye Care. Very, very special thanks to them. It's a great pleasure to see them and interact with them as well. And fantastic comments by all of them. Thank you.
Thank you, Jeff. You want to say a few words? Jeff, are you still in?
Jeff is there.
I think Jeff's gone.
Jeff's gone.
I think he's gone for lunch.
Ragavan and Senthil, just to say your choice of having short cases with the discussion, every Congress I've ever been to, it's always the discussion that's the most useful. And I think that's what your course here has brought out, the discussion where you realize that what you don't know, it's okay to not know it, because not everybody knows it, but the short cases, the discussion is what makes this such a success. That's why it works. Thank you.
Thank you very much, David, for contributing. And thank you all. Special thanks to all of you for being here on a Sunday. And I'd like to thank our man Friday, Karan, in our private practice, who helped me coordinate this. Otherwise, we couldn't have done it with all the background work. Thank you all. And please do fill in your feedback form if you want Royal College points. Thank you.
Yeah, thank you. Thanks, Sampath.
Thank you.